Next, we'll be going for the future, where are we heading? So in this session, we'll delve into some of the most promising new research topics happening in our field. To moderate the first two topics, I would like to call upon Dr. Meenal Chowdhury. She is the Director, Akash Healthcare Super Specialty Hospital, New Delhi, and Dr. Bhagyam Raghavan, President, outgoing President, Society of Oncologic Imaging India, Senior Consultant Radiologist, Apollo Cancer Center. And to deliver the first talk, we would like to call upon Dr. Michelle Mendiretta Lala. Dr. Michelle is a professor of clinical radiology and director of abdominal MRI in the University of Michigan.
All right, good morning. Thank you for coming this morning. Since this is my last talk, I just want to say thank you to the whole SOIICON committee for inviting me to speak and come to this meeting. It's been a wonderful experience, and so thank you so much. So let's start this session. I'm going to talk to you guys about histotripsy. How many of you here know or have at least heard about histotripsy? Anybody? Okay, so let's get into what is histotripsy. How many of you do interventional procedures like ablation here? Can you raise your hand? Okay, so not many. Okay, so what is histotripsy? So this is more of an ablation talk a little bit, but we'll kind of go through the whole thing. Histotripsy is new technology. It would be, when you think about the category of treatments for liver-directed therapy, it's in that non-invasive ablative modality. It's non-invasive, non-ionizing, non-thermal mechanism of action. So what happens is you get these short, high-pressured, focused ultrasound pulses, also known as mechanical waves, which generate cavitation or a bubble cloud. You can see it here in the red circle, the bubble cloud. So you have real-time visualization when you're treating a tumor. You get this bubble cloud at a precise focal point under ultrasound visualization, which results in cellular death. It destroys and liquefies your tissue into an acellular state. So unlike thermal ablation, where you get necrotic tissue or these different types of treatment options, here you get everything into this liquid homogenate, which the body then resorbs. Everyone always asks me, what's the difference then between histotripsy and HIFU, both being ultrasound? The difference is HIFU generates heat at the focal point because you have low amplitude, long duration pulses. Histotripsy, on the other hand, is high amplitude, very, very short microsecond pulses that are applied, and it generates cavitation. When you think of an ultrasound probe, you put an ultrasound probe on a patient, you get an image on the screen because your ultrasound waves are diverging and you get a picture. With the histotripsy, when you put the probe down, all your ultrasound waves converge at one focal point, and that's where all your energy is being deposited. So when was histotripsy? When did this come into play? Histotripsy was discovered 20 years ago at the University of Michigan in our biomedical engineering department. Liver histotripsy research, however, began only in end of 2015, early 2016. So I've been involved in all of the preclinical work in the lab for histotripsy development. We started with asking the question, can histotripsy destroy HCC? And so we put HCC tumor in the flank of mice, and we were able to say, yes, it effectively destroys this tumor type. So then we said, well, can histotripsy actually target the liver? So we did many studies, and we could, without tumor in the liver, but just targeting the liver, and we were able to show that histotripsy can effectively target the liver. So our next batch of studies was, can we destroy HCC in the liver? And again, we proved that we can do that. Somewhere along that line, big company comes in and takes over. So we decided what is we, I'm just a researcher, to translate clinically, okay? So in order to translate clinically, we need to know, can this target safely human-sized livers? So then at the University of Wisconsin, a group out there started looking at larger size liver. So animal model was then a pig. And what happens to the critical structures, right? When we're ablating, we want to know about the bile ducts, the blood vessels, the adjacent bowel, all of that. So they did kind of all those safety, large animal model, human model type studies. At that point, when we proved that it was effective, we moved on to come back to that. We moved on to the clinical trials. And so there was 2 trials. There was a very small Teresa trial in Spain. 11 tumors were treated, and then the Hope for Liver trial. What is the Hope for Liver trial? A recent trial, it just completed. Actually, at the University of Michigan, we were kind of led that trial. It was an international clinical trial. It was prospective, multi-center. We wanted to evaluate the efficacy and safety of Histosonics for treatment of primary or metastatic tumors in the liver. 44 patients were treated. Average age, you can see 50-50 female, male, and multiple types of tumors. We did 18 primary HCCs and then 26 metastatic. So already you can see in this initial study, there's a very heterogeneous population of patients. But the point was not to look for long-term efficacy, it was safety. Is it safe to use in patients, and what happens for local control? So we had 2 primary endpoints. The first was efficacy or technical success. When we treat our target, are we getting a volume of treatment that we expected? And 42 out of 44 tumors had the volume expected, so 96% efficacy, considered a positive trial. The 2 that were not primary efficacy, one of them was because it was one tumor was overlapping another tumor, and so it was considered incomplete treatment because although the tumor we targeted, we got, the ablation zone kind of went into another. They called that ineffective. And the other one was mistargeting by the person who did the procedure. From a safety perspective, there were only 3 complications, 3 major. So CTCAE based on the SIR guidelines, grade 3 or higher. Of 2 of those 3, patient had pancreatic cancer. One was pancreas, one was breast. Both had drains, and at day 18 plus, they developed a liver abscess. Anytime you have a clinical trial, within the first 30 days, it doesn't matter what the complication is. You could have a heart attack, completely unrelated. It's considered a complication for that trial. So I think 2 of them were probably non-procedure related. So anyways, low risk of complication. We just published our 1-year data and shows 90% local control at 1 year. Local control, so just the tumor that you treated has nothing to do with the disease elsewhere. When you break that down and look at HCC versus metastatic, HCC patients did better in terms of survival. Makes sense, of course. Metastatic patients have tumor everywhere. Their outcomes are worse. So now that I presented very briefly the 1 clinical trial data, the question is, should we use histotripsy clinically as a new ablative modality for liver cancer treatment? Right? When you think about microwave ablation, RF ablation, cryoablation, there's tons of data, tons of clinical trial. This technology only has 1 clinical trial, but the FDA approved it, fast-tracked and approved it, and so it is being used clinically. So the question now is, what is the appropriate patient population to use histotripsy, and why is it better than using a RF, microwave? Because most institutions already have that equipment, and histotripsy is very expensive. So let's talk about some advantages, which we've kind of discovered along the way. When we discuss this, just remember, of course, there's limited data on long-term efficacy. So what is one advantage? Tissue selectivity. This is very unique to histotripsy. So collagen-based structures are more resistant to mechanical pressures, and they remain intact after histotripsy. Think about your skin, right? Elastin collagen, you can get bigger, smaller with age. It's very elastic, right? Similarly, with histotripsy, when you're getting this mechanical cavitation, these bile ducts, your epithelium vessels can resist that mechanical cavitation. Here's a pathology slide or a histology slide. This area was treated with histotripsy, and what you see is centrally this intact artery, and on both sides you're seeing necrosis. So you see this blood vessel completely coursing through, showing the safety of treating around large blood vessels. Similarly, bile ducts, here you've got necrosis, or not necrosis, you've got acellular fluid homogenate with an intact bile duct shown not only on histology, but on this MRI with EOVIS. You can see this beautiful ablation zone, this hypointense area, and you see the white bile duct, the patent bile duct with the EOVIS coursing through without destruction. Unlike other forms of percutaneous treatment like ablation, then, the proximity of the blood vessels, bile ducts, and other critical structures are not limitations. So if you look at a central tumor, for example, here, very close to the bile ducts, hepatic artery, portal vein, any other form of treatment would be limited because of heat sink, biliary stricturing, and then from an intra-arterial perspective, often there's a very complex blood supply. So you might treat part of that central tumor, but there's residual from another vessel that you didn't realize exists. On the contrary, when you do histotripsy, you don't have to worry about injury to the bile duct, and so you can get effective treatment centrally with sparing of the critical structures and no heat sink effect. So let me show you some examples. This is a case I did where it's a very large central tumor. Let's see if we can play that again. And you can see the hypo-enhancing area. This is 1 month post-treatment, effective treatment. You don't see any biliary stricturing, which we would see as intrahepatic biliary ductal dilatation upstream from there. When you look at these 3 separate tumors treated, at the yellow arrow, you can actually see intact blood vessels coursing through your ablation zone. This is an expected finding. We'll get into this later. You don't want to confuse that for residual tumor. That's actually one of the thoughts of why they think that you're able to actually get regression of the treatment cavity after a while, because a blood vessel is flowing through and taking out all that acellular homogenate, which also creates this antigenic response, which we'll talk about later. So here is a patient with oligometastatic colorectal cancer to the liver, central lesion, right? If you think of this location, hard to ablate, you have a heat sink, where are you going to put your needle? If you do SBRT, the problem is you can get biliary stricturing and damage to the bile ducts leading to abscesses and cholangitis. Very hard place for surgical resection. So we treated this with histotripsy immediately post-treatment. The whole lesion it's non-enhancing. 1 month post-treatment and 6 months post-treatment, you see eventual regression of the tumor. Portal vein looks great. There's no biliary injury, no residual disease, and it's a very complex location. This patient actually got up and went to work the next day after this procedure. Other advantages is, of course, it's non-invasive, so no needle puncture. In cirrhotic patients or coagulopathic patients, we don't have to transfuse them. If they have low platelets, high INR, they actually can remain on their blood thinners. In fact, we'll get into that in a minute. I keep these patients on blood thinners. Cardiac stents, history of stroke, MI, pulmonary embolus. You don't have to bridge them and take off their blood thinners. Very little post-procedure pain and very rapid recovery, 1 to 2 hours post-procedure. However, not everything is so great, of course. There are limitations. So a couple big limitations is the device. It's a very big device. You can see in the second picture the room setup. So we're doing all of these cases under general anesthesia, even though it's non-invasive. Why is that? Because you think about the liver is constantly moving and we need very precise targeting. And if the patient is awake or even under conscious sedation, changes in respiration can really affect your targeting. So when they're under general anesthesia, I can control their tidal volume, their respirations, make them apneic for short periods of time, and get really good, precise local control. So we have our CT scanner, we have our ablation, this histotripsy equipment. You see the robotic arm. It's a robotic procedure. And let me see if this is working today. It's not working. Okay. You can see the water bath. You see the arm is in that water bath. So that water bath is what we put on the patient's abdomen. We fill this thing up with water. Why not gel? Because gel has air bubbles in it, and those air bubbles actually can seed cavitation proximal to your focal point. So we use degassed water. There's a machine that takes all of the gas out of the water, and we put the ultrasound probe in there. You can see from the first image how big that probe is. So that can be very limiting in terms of locations you can treat in the liver. When you think of your segments, it's very hard to treat higher segments of the liver, sometimes hard to see. We've developed a technique at the University of Michigan where these high lesions you can't see, you can see here shadowing from the lung. What I do is I actually collapse the right lung. I do a single lumen intubation or a double lumen intubation where I put a bronchial blocker. I don't, my anesthesiologist does. Bronchial blocker into the right lung, which collapsed the right lung. And now look at your your ability to visualize this tumor. So, really improves your ability to treat lesions higher in the liver. So transcostal access to upper segment lesions, we were able to achieve that in all our patients without lung injury or complications. The issue again is the technology, the mechanical cavitation, the way it's working is you're seating on air pockets within the cells at the focal point. So if you have air proximal to that, gel, if you use a gel, the lungs, you can actually seed cavitation proximally and cause injury. So we were able to prove that we can do this with lung collapse and not have any injury. I think the biggest limitation, other than being able to accurately target because of the size of the device, is this issue of bland portal vein thrombosis. So what we noticed after our first few cases was, if you see in the second image, that central tumor I showed you a few minutes ago that's by the bile duct, we noticed that after treatment, we were getting some bland thrombus in the adjacent portal vein specifically. And so what we think is happening is the mechanism of this portal vein thrombus, again, this is a theory, is that this mechanical agitation, right? You're causing this mechanical agitation at the focal point, is actually activating your platelet cascade, your endothelial, it's causing endothelial irritation, platelet adhesion, aggregation, and thrombus formation, resulting in this thrombus. So I would say when I said the advantage is central treatments, the disadvantage is this portal vein thrombosis. At University of Michigan, we've also overcome this. What we do, well, first let me show you this. You can see this central lesion, you can see thrombus in the portal vein. What I've done now is I just put the patients on a heparin drip as if they have a pulmonary embolus. They come in with acute PE, you load them, you treat them with IV heparin, so it's constantly running as I'm treating them. And since I've done that, I've done it now, I think on 16 patients, none of them have developed a portal vein thrombosis and no complications. If they develop a portal vein thrombus, you just send them home on a blood thinner for about 30 days. We use Eliquis. Here is a case of a large central tumor. You can see prehistotripsy, arterial enhancement washout. This was an HCC, so an LR5 HCC. Immediately post-treatment, you can see actually an intact blood vessel coursing through the ablation zone here. You see the hypoenhancement, and you can see the adjacent also portal vein branches. No evidence of thrombus in this patient that received IV heparin. So again, now, the first trial I showed you, Hope for Liver, was 44 patients, proved that it was safe. We recently published a paper with 230 patients at 9 centers showing safety data, and there was only 1% advanced complication, and that was death, but it was death because of disease progression. Otherwise, really the main complication, if you want to call it a complication, is a little bit of patients feel as if they did many sit-ups, so kind of a little bit of abdominal tenderness. Let's skip this for time. Sorry. Okay. So let me show you a couple cases that we did. Here's a 42-year-old female with stage 4 breast cancer. She had oligometastatic disease to segment 4B of the liver. You can see on the pre-treatment CT. I show you the setup here, the computer system, the targeting. You can see the red circle on the last diagram is where we're treating. And post-procedure in this patient, I always do an ultrasound with contrast immediately because you see how big that device is. The device doesn't fit into the CT scanner, so I just want to make sure that I got a good targeting. I can leave that device on the patient, give some IV contrast agent with ultrasound, do a quick ultrasound. I see that I have a very nice ablation zone here, no enhancement. Then I kind of disassemble the equipment and I do a post-contrast CT as well, make sure there's no complications. So here you can see on immediate, this is same day, right after the procedure, we have ultrasound and CT showing very nice ablation zone. Here's another patient, very small lesion, arterial phase hyperenhancement. Immediately post-treatment, you can see the ablation zone sign, or ablation zone. It looks almost like there's some a larger arterial enhancing area. That's just the perfusional changes. And over time, at 1 month, at 6 months, and at 12 months, you see continued decrease in size of your ablation cavity. You see smooth peripheral rim, no evidence of local recurrence. There's a trial starting right now. It's histotripsy in the kidney, so it's not FDA approved, but this is just an example of the imaging findings. Immediate, 7 days and 28 days later, it almost looks like this patient didn't even have treatment for this renal cell carcinoma. Again, non-invasive and very good results. I have very little time, but I do want to talk to you about one thing. Yesterday, we had the question, for any of you who were here, about the antigenic stimulation with cryo and how it's better than after thermal ablation. What we noticed when we were doing our preclinical trials with histotripsy is this abscopal response, right? You treat tumor here, what happens to tumor elsewhere in the body? So we have done a couple studies to look at this, and what we've noticed is there seems to be a very profound pro-immune effect of histotripsy on cancer therapy that's related at multiple levels. Histotripsy actually decreases your pro-tumor immune cells. Think about your tumor microenvironment. You've got, how does the tumor grow? It evades the immune system. It has pro-tumor macrophages, neutrophils, etc. Histotripsy, one thing it does is it decreases these pro-tumor immune cells. It actually also, in your tumor microenvironment, when you treat it, creates these damage-associated molecular proteins, which we see after pathologic cell death. So these DAMPs elicit the innate immune system, so you increase your immune-related cytokines, again, at your treatment zone, which results in upregulation of your CD4, CD8 cells, macrophages, dendritic cells, etc., and creates this immune response. It's almost like this tumor vaccine, right? You treat it, and now you increase the immune response. Increases also it changes your PD-1, PD-L1. So when you think about immunotherapy, atezo, bev, durva, tremi, all of these, it's affecting your CTLA-4. So it's got many functions at a cellular level or in the tumor microenvironment. When we did this one study in an animal, and you can see a control animal and a histotripsy treated animal. On day 2, you see an upregulation of your CD11 cells in the histotripsy treatment zone. On day 7, you actually see this change where now your natural killer cells have gone up in your histotripsy treated tumor. Even the tumors that were partially treated have an upregulation in your pro-immune cells. Okay, so that was one study that's really cool. Here's another one. Here we looked at the CD8 T cells in animals with melanoma treated with histotripsy, radiation, RF, or control. And if you look at this last column with histotripsy, really profound elevation in your CD8 T cells compared to the other forms of therapy. The same cohort of mice, control groups, look at the degree of melanoma metastasis in the lungs. If in the histotripsy treated group, you can see what a difference there is in the number of metastasis. And this is with only treatment of one subcutaneous melanoma lesion. So we see this very profound immune response. Here we did a study with immune checkpoint inhibitor therapy plus histotripsy. So we have a mouse. We put 2 tumors in the mouse. We treated with checkpoint inhibitor therapy, tail vein injection. We treated 1 tumor with histotripsy, and we wanted to see what happened to your second tumor. And what we noticed is that the second tumor, so this graph is looking at tumor volume of the untreated tumor specifically. The combination of histotripsy and immune checkpoint inhibitor resulted in a much more profound action on your untreated tumor, meaning in terms of preventing growth. So there may be something here where you have a combination of ICI plus histotripsy, which could change cancer, the oncologic care for patients. Last study I want to show you real quick, I know I'm short on time, I'm very sorry, is the study that we looked at, well, what if we changed the dose? The device I showed you, it's called the Edison device. There's only 1 dose of therapy. We can't change that, but in the lab we can change it. So we looked at intermediate and advanced stage HCC. We put them in different mice, and we changed the dose of our histotripsy. So 50, 100, and 200 pulses per location. And really the main point of this is different tumor grades respond differently to your different doses. So that's something else we can think about for the future. Again, obviously, this is very early with this technology. That being said, I am not a proponent of treating patients for the abscopal response. We've seen it very robust in animals. We have not seen it as much in humans. And so I think we have to be very careful as physicians, as interventional radiologists, some surgeons are using this. We really have to advocate for our patients. Just because in animal models we see this doesn't mean we should use this clinically. We need to have clinical trials. We need to prove it, because you can also get the reverse, where you get the pro-tumor immune system activate, and patients can progress. So I want to leave you with this study. This is from the Teresa trial. This patient has metastatic colorectal cancer. You can see numerous lesions bilobar. 1 day post-histotripsy. Now, none of these were treated. It was a left lobe lesion that was treated. 1 day, you just heard a couple talks about immune system and stuff. You see all of the tumors look a little bit bigger. Looks like they're enhancing more. You're wondering what's happening. We didn't even treat these tumors. 8 weeks later, all of the tumors have now shrunk, and they're not enhancing. And when you look at the CEA, remember only one left lobe lesion was treated in this patient, drastic reduction in CEA. This was our first clinical example of maybe there is some hope for abscopal in human patients. I had one patient from my Hope for Liver trial. Again, you can see this patient has multiple very large metastatic lesions in the liver. We treated one tumor. And what I want to show you is immediately post-treatment, so same day of treatment, of course, there's no effect on this day. Down here, you can see a 6.4 centimeter lesion was not treated. No chemotherapy in this patient. 1 month later, every single tumor got smaller, and 6 months now she's on chemo. Everything continues to regress. But again, while this is very exciting and could be the future of oncologic care, we have to be very careful, and we shouldn't be treating our patients for the goal of abscopal until we have more proof. Remember the goals of local regional therapy. We'll skip this, we don't. So just to show you our data here, we treated 52 patients. This actually is a couple months older now, so we've done more, 68 tumors, a wide variety of tumors, mostly colorectal. So in conclusion, histotripsy is a new non-invasive ablation modality with FDA approval for primary and metastatic liver cancer treatment. Patient selection should be done on a multidisciplinary setting with clinical and imaging evaluation to determine feasibility. When done correctly, we can see excellent local control, but there are device limitations. The role of histotripsy for liver cancer is not fully understood. We need a lot more trials, prospective registries to better understand the efficacy. And I think, again, it's too early to treat for abscopal. We need more data. I don't think this is ever going to replace microwave ablation, ablation, RF. I think it's just another tool in our toolbox. I still think a microwave ablation, the control race and the ease of the technology, it's still going to dominate for cancer care. Thank you.
Thank you, Dr. Michelle, for an elaborate talk. We'll take the discussions at the end. Yeah. Thank you. Thank you so much.
The next talk, I'd like to call upon Dr. Murugan. He's the Chief Radiologist of Clarity Imaging Center, Coimbatore. Sir is going to talk about bone marrow signal changes in spine and when to suspect neoplasm.
Good morning to you all. This is a very basic topic, so you can sit back and relax. Actually, this topic was exchanged with other faculty yesterday because they wanted to leave early. So probably, this is some kind of filler of this is positioned between all hi-fi topics. This is more of a basics, mainly addressed to the residents. Because as you know, spine is something, about 30% of volume of the work will be spine reporting. So sometimes we tend to take advantage. We want to push through the spine reporting so that we have more time for, your complicated other cases. So you have to be strong in your basics. You have to understand what are the normal variations, the so-called incidental lesions, so that you don't overdiagnose. That is the purpose of this talk. So bone marrow signal, okay, how do we make out and when do we suspect neoplasm? That is the topic given to me. Now, just a small question. The residents on your left is the T2-weighted image. How many of you think this is normal, this T2-weighted image? Forget the disc. And we are more looking at the vegetable bodies. On your left is your T2 weight. How many of you think it is normal? I think you're a bit shy. It is normal. It is normal. How many think that T1 is abnormal? You're not sure. Okay, that is the purpose of the talk. See, it's a simple spine. You're not sure. Sometimes to, confidently say, come to a conclusion whether it is abnormal, normal. That is the purpose of the talk. So I got an idea about, how I'm going about. Now, these are the standard pulse sequences, T1, T2, and stir. Okay. On T1, the bone marrow should be bright. Okay, because it's predominantly fat. So you have fat. It should be higher intensity than your muscle. Muscle is reference and disc also. So this is T1 weighted. See, T1 weighted, most of the time we say it's more of anatomical imaging. As far as spine is concerned, this I keep repeating, you should never underestimate or overlook T1 images, because most of the lesions can be seen better with T1 because of the fatty background. Whereas on T2 weighted image, sometimes the lesions can be easily iso-intense, you can miss it. If it is for cord lesions, it's fine. But for marrow, for vertebral bodies, T2, it is not so helpful. So you'll have to keep it in mind. Of course, just to compensate, we have the stir images where the fat is suppressed so that the lesions stand out. Okay, so this is a basic concept. The marrow is predominantly fat and water. Most of the marrow is fat. So on T1, it is bright. When a lesion occurs, it produces water. So the lesion will be hypo-intense on T1. So that is why it is very sensitive. Whereas on T2, because already fat is bright on T2, your lesion also will be bright. So that is the always a small caveat there. You can miss a lesion on T2 weighted image in the vertebral body. I keep repeating this. And in addition to that, we have in the marrow, we have red marrow and yellow marrow. We are aware that yellow marrow appears bright on T1. Whereas this red marrow can be iso-intense. So this sometimes creates confusion while interpreting. That we will come to it a little later. And on top of that, we have another physiological changes, this marrow, fatty marrow reconversion. At birth, it is all hemopoietic and slowly it changes over time. That also we will discuss. So just as I said earlier, normally at birth, it's all hemopoietic marrow. And slowly the marrow reconversion, the yellow marrow fatty conversion happens from distal to proximal. So I've just put an image of T1 weighted image here as a pediatric spine. You will find that marrow is almost iso-intense. That should not be mistaken. So this is very normal finding in a pediatric age group. We will again discuss this further. So then what happens is in the spine, it's a little different. There are various patterns of fatty marrow reconversion. It occurs like this. In the early years, the fatty marrow develops along the basivertebral brain, so-called the type 1. The Ricky and all, they have devised 4 different patterns. All of you may be familiar. This fat occurs only along the basivertebral brains. Then this end plate marrow is not modic. Modic usually you'll find on both sides. Here it is due to age-related fatty deposition, which can occur along the end plate. Not every time it is inflammatory spondylitis. Then this is the one which is confusing. Sometimes this in the background of hemopoietic marrow, this fatty deposits, they're all fatty marrow reconversion. So you might suspect this as metastasis or myeloma. Okay, we will again discuss this. But one small clue is in stir image, generally, as I said earlier, the red marrow appears iso-intense. But in stir, it is not hyperintense. So that is one small clue. You keep it in mind. We will discuss again. So this is also normal. Okay, this is so-called heterogeneous pattern of marrow. These are all marrow fat. And the last stage, the homogeneous pattern, where the entire marrow is converted to fat. That is type 4. Okay, so some signs may be helpful, not always. When you find a hemopoietic or let us say hypointense area, and if you find a bright area in the center, that's called bullseye sign. If it is there, then it is benign. Okay, the previous slide I was showing more of heterogeneous, and if you find a bright area inside that hemopoietic area, that is benign. Companion slide will be the halo sign. This is the reverse. This is a T2 weighted image. When you find a high signal along the margin of a lesion, it's called halo sign. That indicates metastasis. Okay. Again, we will discuss this again once more later. Okay. Coming to the so-called distractions. Sometimes in spine MRI, you will find a lot of these normal variations. A small advice to you, please document them, because otherwise the clinician will call you up. Did you just notice that metastasis you have not mentioned? Invariably, this keeps popping up. So it will be very boring, but then you have to keep on, adding that fatty lesion seen, likely hemangioma or lipoma as per the thing. So usually lipoma, you can see it's bright on T1 and T2 and gets suppressed on SIR. This is lipoma. Hemangioma will be slightly hypo-intense and bright on T2. It is hemangioma, but then it's a combination. Sometimes you can say lipohemangioma. If you're not sure, just you can mention lipohemangioma, incidental finding. Of course, this bone island, all these things, please document, because that's very, very important. You start learning from day one. Another thing which causes confusion is marrow reconversion. We were talking about the yellow marrow changes. After some point, what happens is, because of the increasing demand, especially dietary change and anemia, severe anemia, and high endurance athletes, smokers, you will find the marrow getting converted because of the increased demand for the oxygen. The marrow will be reconverted to hemopoietic. So just like smoker's lung, if you say hypo-intense marrow, you're just out of curiosity, you can ask the person whether he's a chronic smoker. So that's a classical smoker's spine. So, of course, this is a lady, 32-year-old lady, pregnant lady. You find the marrow. So now you're able to understand this is abnormal, because this marrow is almost iso-intense to the muscle. It is not brighter and slightly, even darker than the disc. So this is abnormal. Of course, this is a known patient with anemia, chronic anemia. So this is normal. In such cases, what I do is, always, again, my other take-home message is look around. It is not just the spine. The patient has come to you for a diagnosis. You look at the localizer. In the localizer coronal, look at the spleen, whether there is splenomegaly, because all this can give some information to the clinician, whether there is hemopoietic demand. So all this, or some lymph node also you can make out. Supposing the same picture, when you find splenomegaly in lymph nodes, are we dealing with lymphoma? We may not be sure, at least try to mention it in the report. So it is not just the spine alone. That is another thing I want to keep emphasizing. Then coming to some classical lesions, how they appear on MRI. One such lesion is multiple myeloma. This is exactly the topic I'm coming to. So again, it can be sometimes diffusely abnormal. Just like the case we saw previously, the marrow can be diffuse. In no way we can make out. The more common presentation will be multifocal. It can mimic metastasis in this case. We'll discuss how to differentiate. Of course, it can be solitary also, plasmacytoma, and it can be normal. Please keep it in mind, multiple myeloma can be normal on spine MRI, because even when the 20% of the marrow is infiltrated, MRI can be normal. So that we'll have to keep in mind. Clinician, if they ask if there's evidence of multiple myeloma, you can say no imaging features. They have to go by the other blood test and the protein test to confirm. So generally, multiple myeloma, the lesions are smaller. Smaller, I mean roughly about less than 10 mm, but it's not a strict criteria. And well-defined, punched out, because they are plasma cell and hyperplasia within the marrow, the margins will be well-defined. And generally, so these are all broad guidelines, no paravertebral soft tissue. So this is the reverse of metastasis, where it will be all the reverse. I'll just discuss later. Now, some classical cases, starting from less obvious to more classical. So in this case, the marrow is heterogeneous, and we are able to see some punched out lesions. So probable multiple myeloma. One cannot be sure in this. Of course, the case in the middle is more classical. You can say smaller punched out lesions and this complete soft tissue marrow replacement. This is very classical. The small, multiple scattered, punctate lesions. These are all very typical of multiple myeloma. Of course, the presentation can be like this also, diffusely hypointense. That is where I just keep repeating, whether it could be marrow reconversion, whether it could be leukemia, we cannot be specific about it, but definitely marrow is abnormal. In such cases, you can always ask for peripheral smear if the patient has got some blood report, go through it, discuss with the clinician, and again look around for other associated lesions. As I have the single lesion in plasmacytoma multiple myeloma, which I discussed earlier. Metastasis, just the reverse. Lesions can be a little larger, and of course ill-defined margins, and the paravertebral soft tissue is very typical in metastasis. So also again look around for primary lesions. This is a typical metastatic pattern where you find a lot of bigger lesion, and more importantly, the margins are ill-defined, okay? And also the paravertebral soft tissue. Normally you don't see this in multiple myeloma. Again, pedicle involvement. Again, this halo sign. You can see this T2 hyperintensity along the margins. That's again an indicator. But none of them are specific, but then you can use it for easily the differentiation. Again, as I said earlier, in the lumbar spine protocol, it's a crime not to involve the pelvic bone. At least one localizer, one shot, about 40-50 seconds, you have to do a screening of the pelvic bone to make sure, because it's a very fertile area for metastasis, and most of the patients, if you have a doubt, especially in the not so classical patient, when you find lesions here, you'll be able to correlate and come to a fairly comfortable diagnosis. Sometimes it can be like this. On T1, it is hypointense, and T2 also is hypointense. So what could be the metastasis? What could be hypointense on T1 and T2? Sclerosis. Okay? Probably if you do CT, it will be very obvious. So sclerotic metastasis can occur. And as I said, look around. See, for example, this is dilated ureter. So this is a small clue. There is some obstruction. Maybe it's a bladder carcinoma or maybe prostate. Most of the time, a sclerotic metastasis in male, it's prostate. So what are the differential diagnosis? When you find sclerotic metastasis, again, these are some of the differential diagnoses. Always in male, it is prostate, in female, it is breast carcinoma. Most of the time, 80 to 85% of the time, these are the two commonest causes of sclerotic metastasis. In breast, it could be mixed also, but keep it in mind, it could be transitional cell carcinoma. For example, the previous case, the ureter was dilated. Maybe the patient had a bladder CA. So you can just sometimes advise the tech to do some cross-section if you are, supervising. That's very, very important, because you have to be a complete radiologist. After all these years, I've realized a patient comes to you, it is not just the spine, just look at everything. There's so many cases of lung carcinoma we have picked up just in the localizer, because nowadays the concept of taking chest X-ray, especially, is a forgotten field by the new generation clinicians. Again, if I say the female patient with a sclerotic metastasis, likely primary breast CA. Just a final comparison, multiple myeloma, you find punctate smaller lesions, okay, and well-defined lesions, no soft tissue, whereas metastasis, larger lesions, pedicle involvement, ill-defined margins. So again, so these are some of the cases which we have come across. We have not spent much time. It's just the localizer, I'm telling you, because once you see metastasis in male, look for lung, at least lung, because that's one of the common site for primary, obvious Pancoast lesion. And also in the lung, liver, for example, here, you are able to see a metastasis. There's almost kind of stages the find. Again, another patient, you find that there is a lesion in the kidney. In fact, that tech has not noticed it, but you can see even the axial T2. For example, in axial T2, always look for lymph nodes and the kidney. Most of the patients you will see. Do justice on page, because kidney tumor can be very silent. And in your lifetime, if you keep looking at it, at least 5 or 6 cases, you are assured to pick up undiagnosed kidney tumors. And another less common malignancy is lymphoma. Lymphoma is little unique because it presents with not much of bone destruction, because the lymphomatous cells permeate across the cellular space and without causing cortical destruction. For example, in this page, the marrow is abnormal, and there is a lot of soft tissue, and by contrast, we are confirming it is not abscess, because there is a homogeneous enhancement, it's not abscess. So in such cases, think about some hematological malignancy. It may not be lymphoma, it could be leukemia also. Coming to other common, presentation where we have to be familiar is vertebral collapse. The classical vertebral benign collapse will be preserved marrow, low signal to fracture line, be careful to pick up, and the fluid cleft sign is very, very important. We will see the examples, and multiple compression fractures. For example, from typical to less typical. This is a classical compression fracture. Okay, you can see the posterior sharp margin, no convex margin. This is less typical, but then the marrow is retained. Again, less typical cases, but then you're able to see the marrow still retained. And finally, even this collapse, though it looks abnormal, you're able to see the retained marrow. So that is benign. And also, another clue is there are other multiple compression fractures. Again, cases like this, when you are not sure, carefully look for the fractures. Even sometimes when you are in doubt, you can do a CT scan that shows the fracture very well. and fluid cleft sign. Once you see, even it looks like a metastasis, when you see fluid cleft, it's benign. Okay, that is another take-home message. And sometimes follow-up scan, when in the initial scan, especially acute osteoporotic collapse, when you're not sure, advise a 4 to 6 weeks follow-up. Of course, this patient turned out to be an infection. Then in the follow-up scan, sometimes the fatty marrow will come back and it will appear benign. Malignant lesions, already we have discussed, complete marrow replacement, posterior convexity, posterior elements and soft tissue. For example, here, complete marrow, though these, there are benign compression fracture, this is metastatic. So this could be benign, but definitely this is metastasis because it's complete marrow replacement. Again, posterior bulging, and again, pedicle involvement, again, the halo sign which we were discussing, paraverbal soft tissue. And please do mention these are all fatty lesions. Otherwise, the clinician will think they are also metastasis. Coming lastly, few slides on multiparametric, because this topic has been wedged between the high-fi topics, and this is something, multiparametric is coming in a big way. For example, prostate is well established, high resolution T2 and diffusion. It kind of helps to kind of the staging, the pyrads. So similarly in spine also, there's a lot of interest in multiparametric imaging. You have this anatomical sequences T1, T2 still. We add this functional component. You do the diffusion and this chemical shift in phase, out phase. Let us see what say. This paper finally concludes that combination of ADC. See, sometimes don't get distracted by this diffusion alone. This, please keep it in mind, even in brain. Just because it is bright doesn't mean it is acute or anything. Look at ADC, because that actually tells you whether there is restricted diffusion. So the ADC value and the signal intensity ratio that is based on the in phase, out phase, they are able to kind of discriminate benign versus malignant. But again, this is work in progress. I'm not a big fan, though I have done few sequences. All these sequences, we have to keep it as a problem-solving thing. When you are not sure, when you are sitting on the wall and just take a call, maybe you can use them, but otherwise, don't rely too much on this. But then the concept works like this in cellular malignancy. Of course, there is increased cellularity, so there is restricted diffusion, just like in FOD. So the ADC value comes down. So they say the cutoff value is about 1, easy to remember. And I think if ADC is less than 1, it is more likely to be malignant. For example, this is a spine diffusion ADC image. You can see in this case, ADC is 1.7, benign or malignant. ADC is higher. That means cells are moving around freely. There is no restriction. So this is a benign lesion. And again, this CSI, we have been using it in adrenal for quite some time, as you're all aware. Same thing in spine also, you can use it. You find out the intensity of the suppressed marrow numerator, that is out phase in the marrow will be suppressed, divide by the numerator, that is the normal marrow. You find a number. So normally in malignant cells, because they don't have fat, it will not be suppressed. So the numerator will be higher. So the level will be more than 1, so more than 0.9. So you can say roughly 1. ADC, if it's below 1, and if it is CSI, if it's above 1, okay, you're likely, but don't get sometimes distracted by this. With your experience, the other factors. Keep this as a problem-solving investigations. So similarly, this is how we calculate this signal intensity in the post phase, where it's less divided by the signal intensity in the lower one. So that's about 0.8. So the take-home message, again, I want to emphasize, keep looking at T1, because in a hurry, what happens is when we are reporting, we keep T2 on site, sagittal, axial, and start reporting. Because we are mainly worried about the disc. It is not so. Please look at T1. Next time you find, when you pick up a lesion in T1, please remember me, because I have missed so many cases in cervical spine, especially degenerative arthritis in C1, C2. If you don't look at cervical, you will miss it. Be familiar with marrow patterns and look around. Again, I keep repeating this. You have the simple localizer, look around, and multiparametric imaging coming in a way, but you'll have to have internal standards. You do this in your cases and develop one kind of, just like in the flow imaging in CSF, you cannot have absolute values, but then try to have your own parameters developed in institution. So in problematic cases, it will be useful. Thank you.
Thank you so much, sir. The session is open for question and discussion.
Any question? Thank you so much, Dr. Murugan, for giving us a crash course in marrow pathologies for spine. And I think it is very, very important, as you said, to look at even because mostly these patients are referred from orthopedicians and finally they go to a hematologist. So if we miss, we are the link between ortho guys and the hematologist. And if we miss this finding, of course, the patient is going to have a bad time, and of course, the reputation of radiology department will be at stake. So thank you so much for giving us this course. And any questions or any queries for both Dr. Mitchell and Dr. Murugan? So, Dr. Mitchell, I have a question. Is there a size limitation for histotripsy, like for other ablative procedures? We have a size limitation. Do you have any size limitation for histotripsies as well?
So the maximum diameter you can get is 4 centimeters with one ablation zone. So we say usually you want it to be less than 3 centimeters, but I've treated larger lesions. So we actually use 5 centimeters as a cutout, and I just do adjacent ablation zones.
And any difference between superficial and deep lesions, like where the bone is interfering, or where, bowel, of course, I'm sure is a limitation.
Bowel is definitely a limitation.
What about if the bone is coming in the
You
way
actually
that-
can go through the bone. It just increases the time of treatment.
Okay, sure. So,
And just to add on to that, ma'am, is any limitation number of lesions which can be myself, Priya? Any difference or in the number of lesions which can be treated in histotripsy?
I treated up to 4 lesions. You do want to be careful with post-embolization, almost similar to post-embolization syndrome, where you don't want to overtreat and create this intense inflammatory immune response. I think more than the number that you can treat in one setting, it's a lot of these patients have metastatic disease. So what's the appropriate number to treat, right? I showed you a couple cases of patients with lots of tumor. Those were the original clinical trials. I would say, and so that, they were kind of out of the norm. That was more of a safety study. I think in our everyday practice, you want to follow more of like the oligometastatic literature. So if patients have more than 6 to 7 lesions, I don't think histotripsy is the right treatment for them.
How often do we follow them up? Is there any particular cutoff?
Similar for ablation, so 1 month and then 2-3 months afterwards.
Same thing like that.
Yeah.
Thank you. Any other questions?
Any other questions, please? No, the other thing I wanted to know was like, how have you tried using radiotherapy along with that? Because we do have combination, right? So of course you're doing immunotherapy, but I just wanted to know regarding.
So I have a patient right now that I just treated with it was a cholangiocarcinoma patient, had a left hepatectomy, had recurrence centrally kind of in the porta hepatis along the blood vessel bile ducts, and the lesion was actually quite big. Her CA19-9 was very elevated. Personally, I don't think she was the best candidate for just histotripsy, but the oncologist wanted to kind of downstage her because she's a very young patient, 32. Her CA19-9 was over 12,000. So we did combo for that. So she'd been responding to systemic, stopped responding. So I treated her with histotripsy. I actually got a very big ablation zone, but I couldn't get completely the margin. So then they cleaned her up with radiotherapy. But I don't have, it's very recent, so I don't know. But I anticipate, hopefully, it'll be good results. I think combination is where the future of it is, so.
Thank you very much. Yeah, thank you very much for you. Please take over. Yeah, thank you.
I'd like to thank our chairpersons, Dr. Meela and Dr. Bakia ma'am, for being excellent support. And I'd like to thank Dr. Mitchell and Dr. Murugan sir for their comprehensive talks. You guys are moving on to the next session. For this session, I would like to invite Dr. Ram Kumar, Senior Consultant, Department of Nuclear Medicine from KMCH, and Dr. Shreeman, Lead Consultant, Onco-Imaging from KMCH to share the session. And to deliver our first talk, we would like to call upon Dr. Sikandar Sheikh. Sir is a professor and head of Department of Shadan Institute of Medical Sciences. Sir is going to talk about molecular imaging and an overview. Over to you, sir.
I can start. Yeah, thank you. So first of all, thanking the organizing committee, Dr. Venkatesh and Dr. Mathicharan sir and entire team for giving this opportunity. Thank you all. It was exciting stuff which has been happening since last 2 days. Yeah. So something like this is something out of the box, and most of the things are in preclinical stage, and we know cancer is one of the leading cause of mortality globally, and there are a lot of data based on the different studies, and but still it is one of the most important leading cause of the death as well as mortality and morbidity, and we have two important cornerstones line of management along with the chemotherapy. So coming dot to the topic, actually, we know what is molecular imaging. So it is the imaging modality where biomedical imaging and molecular biology, they come together, and it's a blend of biochemical components, biological effects or biological synergy which happens in the body, diagnosis and therapeutic applications. So there are a lot of definitions which has been proposed and promoted. One of the most commonly used and still being defined is visualization, characterization, and quantification of different biological processes in the cells and molecular levels in the living organisms. And it studies the same cellular aspects as well as molecular pathways, and that is done by the biotargets of the design and preclinical evaluation of specific probes. So how it works actually, it is by administration of imaging agent intravenously mostly, and to define along the biological pathways, and most important, without disturbing the cell environment of the process within the body or a tissue, and the imaging agents like tracers or biomarkers are being used which doesn't have any effect on the body, and these tracers can be molecules or analog of molecules, or they can participate in different metabolic pathways, and they can be also the substrates related with the enzymes, receptors, antigens, and transporters. So this is something very confusing, but you see the terminology tracers is something like all these components will come, and sometimes what we have seen in PET nuclear medicine is radio labeled, and that is a radio tracer which is known in this case. And second component is the technology where the hardware or software which is being used to identify and try to scan that. If you see, there are different things. I'll be coming one by one. So this is a form of optical imaging followed by ultrasound. Then you have MR, then you have radionuclide, SPECT, PET, and theranostics in the last. What is the aim of oncology or molecular imaging in this? So, to identify and differentiate a tumor in a normal tissue at a very early stage, I want to add here, and necessary to understand the fundamental cellular changes which happens in the tumor as the tumor grows, and this can be seen in a form of a contrast. So if you see this like something, it is very precise. If you see this like what we hit at a dot is a target, and the role of molecular imaging is at present in this way rather than surrounding all these structures. So it becomes more specific, and if you see the first modality of molecular imaging is PET, then followed by SPECT, optical, now MR. A lot of new changes in technology has come in MR as well as ultrasound, and combination of these multimodal agents which are known as hybrid imaging existing is PET-CT, PET-MR, or MR optional, or CT optical. There are so many things which are being in pipeline, and targeting moieties are viruses, it can be molecules, it can be the different components of our body, and along with that the basic enzymes, receptors, DNA, RNA, and different physiological states are being used. So what is need of this cancer metabolism? We need to know by molecular imaging whenever there is slight change in the cellular metabolism, number one, whenever there is change in the key for the cancer growth and malignancy, to study the biochemical pathways, any deviation is there. For example, it is a glycolysis. So glycolysis, we know there is a tumor metabolism, increase in the glycolysis, more tumor, more, or it is not only tumor, it can be an infection, but still pertaining to cancer, it is one of the thing. And we have learned in our intermediate school days, like college days, you have pentose phosphate pathway and different pathways, TCA cycles and all that. So ultimately, they are all blend of all these things which
has to be known, studied, and possible with the molecular imaging. And another important aspect is monitoring and understanding the cancer metabolism. So this is based again on this all different entities like enzymes, targets, different pathways which are happening in the body. As one of the example which has been done is Otto Warburg has demonstrated high glucose consumption and lactate production in cancer compared to healthy tissues, and this conceptualized the tumor metabolism differs from that of the normal tissue. So he was the first person who tried to identify and differentiate this. So what is the role? Again, same thing, changes in technology and physiology, then tissue characterization, define the extent and infiltration of the tumors, especially in C2 tumors. This is a very big role, and planning as well as monitoring response to the therapy. So post-treatment changes and all that. So how is it possible? Like I'll just skip this slide. So personalized medicine is a new concept which has come. So this is like diagnosing a disease entity and then tailor-made treatment or management to that particular disease entity. So this is something like which has been come, and probably in down the line of 10 years or 15 years, definitely this will be the concept to identify a particular disease. For example, you have dopamine, you have Parkinsonism, you have dopamine or dopa pathway by which you should be identifying the dopaminergic pathway. Then your focus, you know what happens when there is a derangement of dopaminergic pathway in our body. So that is one of the example by which you can try to focus. Now we know ultrasound is most commonly and most widely used imaging modality, but how come the role of molecular imaging using ultrasound? So this is possible with the contrast agents, and then post contrast, we know that a lot of new ultrasound contrast agents are there which can diagnose different cell processes, different mechanisms. One of the common thing is hepatic lesions, where we inject the contrast, ultrasound contrast, and then try to see they have better sensitivity and specificity because of the evaluation at the cellular level. Another thing is genetic and cellular alteration. So any sort of genetic variations and cellular alterations are also there. Because a lot of diseases what we see are especially congenital disease are more likely genetic, inheritance and all that. So mapping that also is one of the possible thing where we call it as a genetic imaging or gene imaging. That is also one of the component of the molecular imaging. Then, as I told you, most of the studies of this molecular imaging are in preclinical stage, except this ultrasound contrast and some of the PET-CT, PET-MR, SPECT-CT and other things, nano imaging are being used. And coming to, again, important entity is theranostics. So theranostics is very important, and that is also part and parcel of each and everything which is being coming in recently. So one of the important thing is radioactive iodine, so which is used for the diagnosis of the thyroid pathologies, especially neoplasms, and then for the management of the thyroid cancer. So it is like blend where you diagnose and you therapeutic options also for that. So again, what are the possible sound? It can detect tumor angiogenesis. Nanoparticles can be used for that. Multimodality imaging can be added with the photoacoustic imaging. Again, for monitoring response to the treatment, again, anti-angiogenic therapy, post-treatment, you can evaluate radiation, post-radiation, post-chemotherapy, you can evaluate what are the changes. Then image-guided delivery of therapeutics. It is a part of theranostics. So microbubbles can carry chemotherapeutics to the area of interest, and then precise treatment can be done without any sort of morbidity, which will have an impact. So this is more focused than microbubbles along with the therapeutic genes, and then ferromagnetic bubbles. So these are so many things actually which are seen. Now, what can be the range of molecular imaging? If you see the sizes, it is micro to nano. Nano is also there. So nano is something like 1:10⁻⁹. So that is very smallest particle. And if you see the size of the cell, vascular supply at the level of cell, like capillaries and beyond, so it looks very big as compared to the particles which are being used right from the micro to nano. So this can easily be transported as a diagnostic as well as for the therapeutic options. And most important, we know there are different pathways with the cell. So every cell has a specific pathway, specific route by which the nutrients are passing inside the cell as well as outside the cell. So that is the same way where all these things which are more focused, more sensitive will be focused, and then options of treatment as well as diagnosis can be done. This is a use of nano ultrasound, nano bubbles are used and for detecting the extravascular space. So surrounding space by ultrasound. So it can identify the vascular endothelium. Is there any breach is there? Any edema is there? Any leak is there? So this can be done at a very precise level by using the nano bubbles. Microbubble again same. It is slightly larger than the nanoparticle. The size of micro is little less. So same therapeutic options are also there. So I'm just skipping this. Yeah. So nano imaging is also one of the important entity. So there are a couple of studies which are going on and related with the new angiogenesis. There is one study which is going on in our Department of Biomedical Engineering at IIT Hyderabad. So I'm also one of the co-PI in that. So they are trying to study the angiogenesis in the tumor cells in the animal imaging. So by using rats as the animal entity, different studies are being used in that. And the components which are used are the nanoparticles. What we are using is the nano droplets and solid nanoparticles which are being injected and try to see the vascularity of that particular tissue which is being highlighted. So ultimately, we can detect early cancer and monitoring as well as by which you can identify and try to have more precise outcome for better survival rates. So this is one of the important thing related with the ultrasound. Now, multimodalities, combining two modality, PET-CT, SPECT-CT, PET-MR and all that. But along with that here, again that multimodality, the role of molecular imaging is with microbubbles or nanoparticles. So this can be injected and try to identify the different cell and cellular impacts which are happening. So ultimately, ultrasound molecular imaging is still one of the most important cancer tools and therapy, which is coming in a bigger way, but a lot of things has to be done. So we talk very shortly about nanoangiogenesis. We know it is neoangiogenesis, sorry. So angiogenesis, we know it is the increased vascularity, but how does it happen? There are so many factors which are happening. And these are all the different entities which can be used to identify there is increase in the vascularity at a particular tissue and there is an abrupt change or alteration of the angiogenesis in a particular tissue. So these are many things, a lot of literature is available in the Western countries and a lot of studies are being happening and most of them are preclinical. So this is one of the things like preclinical imaging. If you see the B mode ultrasound hyperplasia, this is a breast cancer. If you see, so amount of this is normal by which what we can see by B mode. But if you see the B mode targeted molecular imaging signal, see the amount of the tissue, we know that this is normal. But if you go from hyperplasia to invasive, the amount of the tissue, the sensitivity of the tissue, the amount of the uptake is very high. So this is what which can be diagnosed and try to correlate with the nano imaging particles. This is again the prostatic cancer. If you see it can very clearly signify this is patient 1, this is patient 2. You can identify the abnormal area in this. This is normal ultrasound, contrast ultrasound. But if you see inject with the nanoparticles, then definitely this is only the area which is probably the tumor and rest of the tissue. So there are a lot of false sensitivity results also in this. It has to be very meticulously planned and try to correlate. Now another important entity is spectroscopy. We know spectroscopy we use in our day-to-day practice. A lot of things are there. We analyze metabolites. Ultimately, what are metabolites? They are metabolites of the cell by which we can identify, and we use mostly the proton MRS. But if we go through the basics of MR, there are so many things which we need to understand for the impact of the molecular imaging. So there is something like spectroscopic imaging. This is our, other than our spectroscopy, what MRS, what we are using. It is a spatial mapping of endogenous metabolites. Mapping is done here rather than the tracing what we do in MR spectroscopy. So this is something which is different from the normal MR spectroscopy. There is hyperpolarized MRI in cancer. So this is also there where carbon is labeled and then there is, we can measure the amount of glycolysis in cancer. And again, pyruvate and hyperpolarized, this lactate is also being used in different stages in mouse and preclinical imaging in animals. So CEST is also part of MR. So it is like chemical exchange saturation transfer. So it is like using the different saturated frequency, which is selectively radio frequency saturation pulse, leading to zero magnetization. So it is a part which is technically altered and then try to identify what are the changes. So again, the basis is MRI only. This is a part and parcel of MR imaging. So again, mobile protein peptides and all that, they are also part of cancer. And using this amide, the imaging is known as amide proton transfer imaging. So this is also part of the imaging entity. So how there are a lot of things I told you about genetic imaging. So this is MR. You have mRNA, reporter protein, substrate or probe. So reporter gene is there, which is promoted and then enters into the cell, and this by which there is an interaction. The MR signal is formed to identify any changes in that. So that is a part of the gene imaging, genetic imaging, which is there. So cancer immunotherapy, we had a talk in that, but there is again a role of MR imaging of identifying different cells. So cells can also be tagged and identified before the therapy as well as after the therapy. So this is a part of molecular imaging. So nanoparticle is again coming in a very big way. So a lot of therapeutics are there, a lot of entities are there which are being used in the nano medicines. So not going in detail about this, but so there are some targeted nanoparticles for drug therapy, for radionuclide therapy, and for imaging. So it is itself is a specialized entity for nano imaging. So again, for the diagnosis as well as therapeutics, because nanoparticles can be transported to the cells and then we can diagnose particular entity, especially related with angiogenesis, movement of cell, activity of cell, changes in the enzymatic pathways, and then treatment management also. We can track it, how it is going on, and a lot of biomedical research is going on in this. So still, and I had told there are a lot of nanoparticles. So these are a couple of things like you have polymers, dendrimers, liposomes, micelles, then polymeric, then inorganic, carbon nanotubes, nano cages. So these are different things which are being used for different entities. And if you see this molecular imaging, you have ultrasound, you have optical, PET, SPECT, CT, MR. So all these things are combined in this entity. So I'll just rushing it. So stem cell imaging is also one of the important entity which has come by using different modalities like PET, SPECT, MR, and optical imaging modalities like bioluminescence imaging, FMT, and near infrared fluorescence. So many things are coming in this related with the stem, because we know stem cell therapy is given. So stem cells also be evaluated whether they are responding or not. Fluorescence, light emission is also important entity which is known as photoacoustic imaging. This is combination. Then you have photoimmunotherapy and fluorescence. They also use, like, this is one of the literature which shows this is a normal thing without using the fluorescence, and this is with the using the fluorescence imaging. So another important entity is Raman spectroscopy scattering. So this is one part of imaging. Optical imaging is also one of the part. Bioluminescence, then combination of these entities are also coming in a big way. Genetic already I have shown, then tumor selective promoters. So if you go through it, they look so complicated, but lot of things, lot of biomarkers are being used for different tissues. So ultimately there are a lot of then coming to the SPECT is also there. A lot of functions are there: monoclonal antibody, Fibody molecules, peptides. So if you see this body entity, this is a combination of nuclear, MR, and photoacoustic imaging. This is a cell, and this is a mechanism by which a lot of things are happening, a lot of modalities, animal imaging as well as human imaging. So I'll just finish in quickly in a couple of seconds. So there is one again important entity related with MRI, that is dynamic glucose enhanced MRI. So something related with like FDG, what we inject. So this is also a component by which you can quantify the amount of glucose in a particular tissue by using the MRI. So this is something in a preclinical stage. And this is one of the literature what it shows, like quantifying and identifying the different aspects of the tumor. If you see, this tumor is seen in this right frontoparietal region. Different mechanisms which are happening. Theranostics is again an important entity. So combination of diagnosis as well as treatment is known as theranostics. Different pathways are there, different cells are there. Now, ultimately, last two slides. So this is a PET scan, photoacoustic, again diagnosis and therapeutics, where we combine thermotherapy, radiotherapy, gene therapy, chemotherapy, photodynamic therapy. So diagnosis in side and the treatment part or therapeutic aspects in another side. So this is same thing related with the use of ultrasound. So these are two books which I have written. There is elaborate discussion about molecular imaging in this book, and this is purely based on nano imaging, which I have written on 27 chapters are there in this. Different aspects of nano imaging in depth detail. So this is available by Springers. So thank you all for your kind attention. Thank you.
Thank you, sir, for the amazing session. You've shown us how these tiny particles can make such a huge impact in imaging and treatment. Our next session is on new tracers in PET by Dr. Murali Krishna. I kindly invite Dr. Murali sir to the stage, who is a senior consultant and lead of Kaveri Hospital, Chennai, also the president of TNPY IRIA subchapter. Over to you, sir.
Good afternoon. Okay, at the outset, I would like to thank the organizers for taking the bar up for SOIICON. I think it has been the best SOIICON ever organized, and all the best to Bangalore for the coming year. And my special thanks to Dr. Matthew and Dr. Venkatesh and the entire team at KMCH for pulling this fantastic show. The newer tracers in PET City in the next 20 minutes, I will just discuss, what are the newer tracers that we have, now doing at PET other than the regular FDG. So before that, a brief on what are the indications for PET. Usually the oncological indications like baseline staging of PET tumors, response to therapy, evaluation of SPNs, and these were what we have been traditionally using the PET for, but now we have come up with a lot of non-oncological indications for evaluation of dementia, for tuberous sclerosis, epilepsy, for movement disorders, for cardiac viability, and for pyrexia of non-organs. Still about 90% of the work is still oncology, but now we have a lot of non-oncological indications coming in. And 18F FDG, what we call the magic molecule, has been the mainstay for PET CT, and still is almost 95% of all the work still revolves around 18F FDG, because it's something that can easily produce from the cyclotron. It's got good half-life, and basically it works on the glucose metabolism. So, and when tumor cells which have a high level of metabolic activity than the normal tissues, then the higher level of glucose membrane transporters are there, which helps the FDG to combine with it, and that's where we get these images. So, but the problem is that the FDG also has a lot of organs which have increased glucose metabolism, like the brain, the tonsils, and so many of these. So because of which, some of these organs are difficult to image using FDG, especially when they have tumors. So where all we see increased uptake, whenever there's a high-grade tumor, when there are a large number of viable cells, when there is increased tumor flow, when, of course, in inflammations and infections also, and tumor hypoxia, acute radiation, acute chemotherapy, these are all places where we have increased uptake. And of benign lesions, if there's necrosis or, some bronchoalveolar carcinomas, because they have very low glucose metabolism, we see that there is very decreased uptake. And the limitation of FTG is that, again, as I said, cancers with little or no increase in glucose uptake or metabolism, it doesn't help us. And cancers of organs which have a very high uptake, again, the tumor gets is not able to be clearly seen in those organs. So now, after a few years, now we are seeing a lot of non-FDG PET tracers, and they have become very specific. Based on the function of, based on skeletal imaging, cellular proliferation, amino acids, hypoxia. We will discuss a few of these tracers which are now available in India, and how we are impacting our imaging in PET CT and oncology. So other than 18F, the PET CT, FDG PET, we are also using fluoride PET and DOPA PET. So these all have to come from the cyclotron generators that we have in a few places in India. Whereas the gallium generators are something that you have within your own hospital. So in that, we can generate the PSMA, the DOTA, the FAPI, Exendin. So these are some of the ones which are commonly being used now and quite established as, markers for different tumors. But then we have now moving to these non-oncological indications like the neurology, cardiac infections, and even in therapies. So for that, we are using not only FDG, but we're also using other markers like FDOPA, gallium-68, substance P for gliomas, cardiac PET-CTs, and viabilities with MR perfusion. So what basically with PET we are trying to do is we are trying to uncover every molecule. Before it was only FDG, but now we have PSMA, DOTA, FAPI. These are all now become mainstay, in imaging of those specific tumors. Fibroblastin or FAPI is something that has been now around for almost 3-4 years. We were very excited with it when it was first came. It has this affinity towards cancer-associated fibroblasts. So these are when the stroma of tumors that have desmoplastic activity. So one of the important factors responsible for tumor growth, invasion, and metastasis. So they are able to combine to these. The fibroblastin active protein inhibitor is actually able to combine with these agents, and because of the longer retention by the tumor cells, this is now becoming a replacement for a PET. So initially when we started off, it was said that it could be used only for stromal tumors. But then all the false positives that we used to see with the FDG is now we are able to not see in FAP because the uptake in the liver, uptake in the brain is all less when compared and here. So before it was, as I said, it was only for stromal tumors. Then now it is now picking up for sarcomas, esophageal cancers, breast cancers, lung carcinoma. Slowly, the role of FAPI is becoming more than than what we had initially predicted. So now for HCCs, again, we know that FDG is not very useful. So FAPI is now being used for evaluation. Like if you can see, this was a case of HCC treated. So there was a residual lesion, big necrotic lesion. Whether that is residual disease or not was a confusion. But when we do the FAPI, we see that there is increased uptake at the periphery of the lesion, and which is suggestive of residual disease still at the periphery of lesion. So again, if I'm comparing with PET and FAPI, this was an invasive stromal tumor. PET was not actually picking up the uptake, but when we see the FAPI, it is saying that we are seeing an invasive tumor in the right breast. Again, bone, of course, for brain, MR is always best. But then when we're doing the FAPI, the big advantage is this: there's no background uptake in the brain. And even lung tumors, as I said, these metastases are better picked up if the stromal density is high with FAPI. And for peritoneal carcinomas also, this was a case of peritoneal carcinoma, diffuse peritoneal disease. You can see this is a FAPI. We are seeing increased uptake in the entire peritoneum disease. So what initially started as only stromal tumors is now FAPI is being used for several other tumors. So what is the advantage is that it can be generated and it can be done whenever you want. You don't need a fasting, and patient need not wait for a long time. You do synthesize the FAPI, inject, and do the scan immediately. Now, PSMA, now gallium PSMA, I don't think now we need to discuss it as actually a newer molecule, because it is now the established the molecule for prostate imaging. If you have a prostate cancer, and even if the consultant writes for a FDG PET, talk to him, change to a gallium PSMA, because the sensitivity of gallium PSMA is more than 80-fold for picking up tumors and metastasis. So basically, it is very, very sensitive because it's highly associated with tumor angiogenesis, and the PSMA overexpressed, particularly in poorly differentiated and metastatic lesions. So where PSMA plays a big role is that when we do combine it with the MR, and you can fuse the MR with the PSMA, and then you can actually give the full staging of the prostate cancer. And the problem always comes with these 1 millimeter, 3 millimeter, 4 millimeter pelvic nodes that we usually pick up with prostate, because the bone mets, if it is that, is quite established. If prostate tumor, anyway, the local staging is done by the MR. But then these nodes is when we get a problem with, and then PSMA is very, very sensitive for that. Any small node that you see, if it is PSMA positive, then 100% we can call it as a metastatic node from the prostate. Gallium-68 daughter-like PET, now again, it is got is established for neuroendocrine tumors. It is a very, very high affinity for SS2 and 5 receptors, so which are usually seen in well-differentiated neuroendocrine tumors. So if it's a poorly differentiated neuroendocrine tumors, which is, when the Ki index is greater than 20%, daughter neck is not very sensitive. So usually these cases, the biopsy is already done. We have the Ki index, and when we stage it, you select the molecule that we require based on the Ki index. If it is low, then go for a daughter neck. So if you see here, this is a very, very small nodule in the stomach. So if you have done a PET or if you traditional, even ultra endoscopy, sometimes they miss these lesions. But now we have a focal uptake in the gallium. We know that we are looking at a neuroendocrine tumor of the stomach. See again, this patient presented actually with multiple hepatic metastasis. We are searching for primary. We can see that there's focal uptake at the in the jejunum, and that becomes a primary. So gallium helps us. The biopsy is already done, so we already know that we're dealing with a neuroendocrine tumor. But then to identify the primary lesion with only CT becomes very difficult, and gallium plays a very important role in identifying and picking up meds. You will see that the small uptake that we are seeing here is actually a metastasis of the vertebra. And again, in brain mets, the gallium plays very, very easy role because again, no uptake in the background uptake in the brain. You have this edema. We know it is metastasis. If you have done MR, there's no problem. But if you don't have an MR, but this gallium, you fuse it with MR, and we are sure that we are dealing with the metastasis here. So these are the other newer molecules, not commonly used, but but easy. If you already have a gallium generator in your institute, and these are all byproducts of these, you just have to put this kit and do it. So, and when we get specific patients for that, I think you have to educate your clinician and try out these molecules, but you get excellent results. Like this one, gallium pentoxy-4 is primarily involves the for multiple myeloma is the molecule of choice, because when we have always done, when we do PET, the images you see diffuse uptake over the marrow, but focal lesions, pentoxy-4 will pick up really well. I'm just comparing. See, if you can see here, this is the difference between a PET, FDG PET and a pentoxy-4. You see, there is diffuse bone marrow uptake, which we are, we are seeing in the pentoxy-4, and it helps us in the follow-up after treatment. So we see that is a decrease in uptake in the images that were post-treatment, whereas FDG remains the same in both these studies. Again, these multiple focal lesions of multiple myeloma in a pentoxy-4 lesion, whereas FDG is not at all sensitive. There is no point in doing an FDG until there are plasmacytomas or a focal lesion with a large soft tissue. That's when FDG picks up. But if there are marrow lesions, then pentoxy-4 is the choice of molecule for multiple myeloma. So these are again newer molecules. This is, of course, you cannot do it in your generator, but you can order for this from your FDG vendor as well, because these are again byproducts of the cyclone. This is FLT. So this is very, very useful for following up staging of Hodgkin's lymphoma and high-grade NHL. Of course, we have always used FDG for lymphomas, but then when there is confusion whether there is an infection or a lymphoma that is going on, or whether we want to stage the progression or see residual disease, FLT is very, very useful. If you can see here, the distribution of FLT in a lymphoma, if you can see, there is diffuse marrow, the nodes, and the uptake in the brain is less. The liver is equivocal. This is when the confusion. Suppose there is a post-treated patient who's gone had a lymphoma post-treatment. Now we are seeing a few nodes, increased uptake in in the vocal cords. But then when we do the FLT, we see that these nodes are not picking up because there is no uptake in inflammation in FLT, because it doesn't work on the glucose metabolism. So whenever we have a problem to differentiate between an infection and residual disease, FLT will help in lymphomas. And it has a direct correlation with the Ki-67. So it actually helps us differentiate between low-grade lymphomas and high-grade lymphomas, and also helps in treatment response evaluation of lymphomas when we do pre and post FLT studies. Exendin, again, a very, very specific molecule, very interesting. It has an affinity towards the beta cells of the pancreas. So, Exendin is used for picking up, insulinomas. And also, of course, if it's an institute which does pancreatic transplants, then you can also use Exendin for evaluating the pancreatic tissue post-transplant. So this is again is a patient who had hypoglycemia, waves of hypoglycemia, then normal, again waves of hypoglycemia. So they were looking at, you can see the CT, you will not pick up the lesion. Even when we did the contrast, you will pick up the lesion, but then focal uptake using an Exendin, because of the history, we know the patient is having some sort of hypoglycemia frequently. The endocrinologist said it could be an insulinoma. So I straight away did an Exendin, picked up this small lesion in the pancreas. So very, very, if you pick up this is a life treating, you just have to remove that lesion, the patient becomes absolutely normal. So, and again, as I said, in quantifying the pancreatic transplant patients, this is a patient who had a double transplant, kidney as well as the pancreas. So what happens, because there is an affinity towards the beta cells, so there will be increased uptake along the beta. So if suppose we are dealing with a rejection, then we will know that there will be decreased. We can actually calculate the volume of the pancreas which has been transplanted, and then correlate it with the volume that was actually kept. So this will help you to tell the transplant surgeon whether this pancreas which has been transplanted is actually going for rejection, or how much of residual beta cell is there, whether this pancreatic transplant will work or not. Gallium citrate is very, very interesting molecule. It is used mainly for for bone infections. We have this problem, especially when the patient has been operated. We have an implant there. Whether this implant is now continuous plain, we do FDG. There's so much of artifact. Whether this uptake that is coming is because of the artifact, or is there an actual infection there? This gallium citrate is very, very special. If you are seeing an uptake around the prosthesis in a gallium citrate, there's definitely prosthesis infection, and this has to come out. Even in old fractures, chronic fractures, there is if you see there is an uptake at a later stage, then we know that the bone is going for osteomyelitis, and it again becomes very specific for in treating these patients. Technetium maintenance phosphonates, it's a well-established tracer for the diagnosis of bone metastasis. Bisphosphonates, as you know, also used for treatment of actually bone metastasis in end-stage disease. So same process. So osteoporosis, osteodeformance, bone mets, multiple myeloma. This is again a very useful molecule. Diffuse bone mets, when you're doing follow-up of bone mets, actually this molecule is very, very useful. DOPA, again, the molecule is not very easily available. You have to ask your slightly expensive molecule, but it is produced by cyclotron vendors, and it has got multiple functions. Just because of its availability or the cost, it is not picked up as a regular molecule but then if you're having specific conditions for Parkinson's, insulinomas, again glomus tumors, pheochromocytomas, staging of pheochromocytomas or paragangliomas, we can use 18F of fluorine DOPA. This again is a case of 13-year-old boy with relapsed neuroblastoma. We do an F-DOPA, and you see the extensive bone and marrow metastasis in F-DOPA. For Parkinson's, actually, as I said, it detects the loss of functional dopaminergic neuron terminus at the striatum. You can see that is the normal, and this is a patient who's got Parkinsonism. And also it helps us to differentiate between the essential tremors and Parkinson's syndrome. And this is what primarily now DOPA is being used to. So if you have these, because usually the cyclotron guys produce the DOPA only once in 15 days or once in 10 days. But when you have these type of patients, you can ask them to wait, get the DOPA, and do your study, and you get good results. These are now two new molecules I'm introducing. The one is FES. FES has again been around for about 6-7 months now. Slowly it is now getting available in India. it could be the future for breast imaging because this gets tagged with the estrogen positive breast tumors. So almost 80 to 90% of the breast tumors are, estrogen positive. So this, gets tied up with your breast tumor, estrogen cells. And unlike FDG, FAST uptake is not seen in inflammation, again, degeneration or any reactive process. If you can see here, this is the breast lesion with metastasis, and it picks up good uptake in these patients. The only problem with this is the liver, because it's got increased liver uptake. So whenever there's an underlying liver metastasis, you could miss. But then for pleura, lung metastasis, this is a wonderful molecule, FES. And if you can see, this is when there is a problem. See, this patient had undergone surgery for the breast lesion. Now he's got nodes. He's got an internal mammary node. He's got an axillary node. But when we do the FES, we see there's only two uptake. There's one axillary node and one internal mammary node which is picking up. So only these are positive nodes. The other ones which the FDG picked up are actually inflammation post surgery. So in these problems, it's a very good problem-solving tool. FES again, now slowly getting available. The last molecule, I just want to introduce to you also. It detects hyperfunctioning parathyroid tissue and imaging of head and neck tumors. So whenever, we always used MABG for, parathyroid tumors, but then sometimes you never get the right, if you can see in this patient, if you see compared to the other molecule, the gallium trivexin is actually able to pick up the nodules of the parathyroid, both in the upper lobe as well as in the lower lobe on the right side and on the left side as well, whereas MABG just picked up one lesion. Post-treatment, again, MABG here did not pick up any lesion. Known case of primary parathyroidism. Now you can see that trivexin is able to pick up this focal lesion at the lower lobe. So just before I finish, I wanted to touch on the therapeutics. So basically the same concept. We know how these molecules are working. We know how they are getting tagged up, as Dr. Skandar just said in the previous talk. So we are using the same molecules to tag to the tumor cells, but actually use it for treatment. So we know that gallium dotanek is going to combine with the neuroendocrine tumor, tag lutetium with it, give high dose, and use it for treatment. So that way, when we give chemotherapy, it is, bind, and we are going to target all the cells in your body. But with therapeutics, we are going to target exactly on the tumor cells. You know where the tumor is. Instead of shooting blindly, we are going to hit exactly at the tumor, and and that's when the response is better for these patients. So in conclusion, we now, as I said, several tracers are now available other than FDG. More than after we get educated about these molecules, you have to keep telling your referring physicians about these molecules. Only then they'll write to you, or even if they write, then you discuss with them and change from FDG to other molecules. And most of these tracers are non-cyclotron dependent, which means it is in your department, produce whenever you want, and inject it to the patient. No fasting or other preparations is required for these gallium generated tracers, and no waiting time, and it will actually give better results than 18F FDG. So I think it's time that we move beyond FDG in imaging of in PET-CT. Thank you so much.
Thank you, sir, for that wonderful talk. We understand that molecular imaging is the way forward in onco-imaging, especially in the era of immunotherapy.
Yeah.
We cannot rely only on morphological imaging. And we have quite a few molecular imaging in nuclear medicine than in radiology. And I think Dr. Ramkumar will be the right person to speak on that.
Thank you, sir. That was an exhaustive list, actually. You actually covered all the traces which are available. Have you tried gallium-68 ubiquitinin, sir, for infection imaging?
We don't
So
have
that ubiquitinin kit is available with BRIT, and we have tried for quite a few cases.
Okay.
So it's equally good for infection imaging. So that is one.
We can tag it with our
Yeah, sir. We can really tag it with gallium.
Okay.
I just want to have a quick comment or clarification. The short half-life of gallium-68, that is 68 minutes. Do you think gallium-68 can replace FDG in the future? Because to put it as an example, in our department, the daily FDG is 25-26 cases. So is it going to be possible that gallium-68 will completely replace?
It will not replace that.
Okay.
That is a workhorse, just like our CT. It is our workhorse. But then, when we identify these specific diseases or conditions, I think we have to start using other molecules. That is the take-home message.
Understood, sir.
Yeah.
Understood. Thank you, sir. Thank you.
Thank you so much, sir. I'd like to thank both our chairpersons and the speakers for their wonderful session. For the next talk, we'd like to call upon Dr. Anbar sir, Senior Consultant Radiologist from Aran Diagnostic Center. Dr. Anbar sir, Senior Consultant Radiologist from Aran Diagnostic Center. Professor Dr. Neha Bagri from Vardhan Mahavir Medical College and Safdarjung Hospital. For the first talk, we would like to call upon Dr. Professor Sandeep Bhuta, Neuroradiologist, Director of Research in MRI in Griffith University, Australia. So it's going to talk about HPV and oropharyngeal cancers in the Indian scenario. Over to you, Dr. Sandeep.
Okay, thank you. So I'm on my last leg here, and I would like to thank again the organizers. I can't express this in words as to how special and warm I have felt coming to Coimbatore by this team. I've done lectures all over the world, but I don't want to miss one specific person, so I don't want to use the names, but I've never felt so warm, and it is like I can't express in words. It is an exceptional experience of coming here, and this team is amazing. I would like to give you 5 stars and kudos for the committee, for the meeting, and the organization. Thank you so much. So this is a topic which is dear to my heart, but after having a conversation with some of my other colleagues locally, I'm not sure how relevant it is for the Indian population, but I think the reason I want to present it here is really for the next generation, Gen Z, millennials, whatever the generation after, because you are going to see more and more of these in future. So as long as you know what it is, then it is important. So go through oropharynx, what virus is, what is HPV status. We know that role of surgery and robotic surgery. So this is very interesting from Western world point of view. If you look at this graph, nobody smokes in the Western world. It is very unusual that I know of one of my secretaries, she's Scottish, and she's the only smoker I know of. Nobody smokes in Western countries anymore. The incidence of cigarette smoking has gone like ridiculously down. And one of the reasons I mentioned yesterday is because the cigarette pack costs $40. No common man can afford cigarettes in the Western world. So the incidence of smoking has gone down. Now there is more vaping. All new teenagers are into vaping in Australia. But because it's cool and you look sort of, this is rose flavored or whatever it is. But it's still, tobacco and smoking is still a big problem here. And this was an article I found online, and it was really interesting, which kind of said that, we need to sort of remove the stigma of, you got a sexually transmitted disease, which is an HPV, and we have to work on the grassroots level. It was really nice article to read about, what's happening in India. It's predominantly a male disease. And this is the stats what I could find. And I think this is what the conversation I was having with some of the colleagues in the break, that the way we see HPV cancers, we see virgin HPV cancers. So those patients are not necessarily smoking or have tobacco use. And I think in India, will be impossible to find someone who is a virgin HPV cancer. There will be a mix of tobacco, cigarette, and HPV, and I don't know. And I think only time will tell how this is going to work out. But the incidence of HPV-related cancers are definitely rising in India. The cervical cancer as well as the oropharyngeal cancer. These numbers are actually, I was quite shocked that the numbers are fairly high. I wasn't really expecting this. So 7% of the global cancers of head and neck come from India. 1 out of 13 HPV tumors are HPV related. 6 out of 10 cancers are actually, so more than 50% of tumors we see here will have a HPV positivity. This was a very interesting article by Chaturvedi and his group in 2011. And if somebody would have looked at this article, they would have made fun of him. But if you look at this black graph, this is smoking-related oropharyngeal cancer. And he said that by 2030, which are only a few years away, there will be no smoking-related oropharyngeal cancers. And the blue line corresponds to HPV related. So our experience when it comes to oropharyngeal cancer, 80 to 90% of our cases are only HPV driven. We don't see tobacco or smoking related oropharyngeal cancers in the Western world. So that's how the dynamics have changed. So we definitely have new entrant in the game, which we didn't expect, because we have had a very good handle on cervical cancer and how the pap smear and the screening program and all that. But we never realized that the virus has already changed the postcode and has already gone somewhere else. So this is the new concept. This is a very important slide, and it does matter, because if you're unlucky enough to get a HPV cancer, you're better off getting a HPV positive cancer than a negative one. And the reason for that is that the prognosis is better. So you can look at it here. Histologically, they are different looking. They are basaloid type, not keratinizing. At 2 years' time, about 95% of patients are alive or disease. So definitely a better prognosis. And AJCC realized that one size fits all is not going to work. And the classification for non-HPV and HPV should be different. So we have a different AJCC classification for HPV cancers. So what is relevant here is the tumor size. It's pretty straightforward. Most of the primaries are very small, 2 centimeters or 4 centimeters. But what is relevant here on the whole B side in the morning, there is a lot of talk about nodal disease and extracapsular spread and all that. Doesn't matter in when it comes to HPV positivity. And honestly, I can only tell to the juniors that don't be too fussed about lymph nodes and hilum and all that. It doesn't matter. The surgeons are going to take the lymph nodes out. Don't be paranoid about that. So you can see here histologically, your pathologist is going to have no problem in identifying what's positive or HPV negative, because it's clear cut. It's very, very different looking on histology slides. And here, the risk profile, definitely HPV negative related disease is from smokers, and this is sexually driven. So most of these patients will present to you. Typically, a middle-aged man will say, oh, hey doctor, I was shaving and I found this lump on my neck. It is not doing much. It has been there for a few months, and I've been sort of, putting up with it. So this is the most common presentation of a HPV positive tumor, because the primary tumors are small. And what we are looking for is a cystic change in the lymph node. So here it is, just to give you a brief idea about how the tumor can spread. I'm going to quickly go through it. What I want to really talk about is the CT. Most of the patients would have had a baseline CT. What you find are these really large cystic looking lymph nodes. So if you find a very large cystic looking lymph node in the neck and have a very low Hounsfield unit, always think that this could be a P16 positive cancer, and this may not be your conventional types. I spoke a little bit about dual energy or spectral CT. If you're lucky to have one, if you're going to give one CT to the patient, it got to be a dual energy CT and not a conventional CT. And the reason for that, you get a slider where you can change the value of the KEV. We use 40. On 40, your tumors are going to stand like this, bright as a button. You'll have no problem in identifying the primary. And you move the slider to 80 or 100, and you reduce the iodine boost signal. And I mentioned yesterday in my larynx talk, if you can measure the iodine density more than 2 milligrams, definitely going to be a tumor. So that's the utility of dual energy. In comes to MR for HPV positivity, it's pretty stock standard stuff. You look at the primary, we look at the lymph nodes. The only difference is the ADC value of the lymph nodes. These tumors being cystic, they are often bright on T1. They will look like a cyst, and the ADC value can be very high. And high ADC value tells you that this cystic lymph node is actually not gonna do better. These cystic nodes will often stay like that after chemoradiotherapy. So a patient will have had a follow-up MR or PET 12 or 16 months down the track, and these cystic nodes will still stay there and qualify for what is called as a salvage dissection. PET-CT is the mainstay for HPV positive cancers, because all the trials are driven by the metabolic response. So this forms the most important part in the work of HPV positive tumors. I'm going to show you examples. This is a stock standard. This is something, even I'm old, I grew up training with this, that you have a solid primary and a necrotic looking solid mass. We know this. This is oropharyngeal cancer. It doesn't look much different. Here's another example on MR, very large, bulky primary tongue base crossing the midline. You have extranodal extension or extracapsular spread, necrotic looking unilateral lymphadenopathy. So this is the stuff we know, and we've been sort of learning this from our day one in radiology training. Just one more point, if you're looking at oropharyngeal primaries, create a sagittal oblique image and look for any, this is a bite taken out of the mandible, so this is bone erosion, not very common, but you'll often. And this is a amazing example to show you. This is often called the mother of extracapsular spread, or ENE, because this is a complete mess in the neck. You can see you can't identify a single lymph node, and all the lymph nodes are matted. They are stuck to the sternocleidomastoid muscle overlying skin. So this is a really highest grade of extranodal extension. This is just to show you how we look at it and how a surgeon sees you can see here, sorry, that's epiglottis there, and you can see this sort of bulky looking lobulated cobblestone mass, and that's your right tongue base primary. So it is pretty straightforward. Often we'll have no problem, we'll agree with the surgeon, the way they see it and the way we see it. Now this is what I always keep this case. This is a historic case, probably 10, 15 years ago. This patient had this cystic node, and the way we look at it, we being teaching hospital, these patients are often treated for a suppurative node or infection or antibiotics with GP. They spend months and months trying to figure out what's wrong with them, and they would have often get an FNA which is non-diagnostic. And then to come to our place and we realize that this thing was there 18 months ago, and it has taken that long to identify that you actually had P16 positive cancer. This is more modern or newer case, and you can see how massive these lymph nodes are. And that's why it makes sense not to have extranodal extension and not be too much worried about the lymph nodes. Otherwise, this will be a very high TNM stage disease. So these are cystic lymph nodes. This is what I was talking about with MR, that if you do MR on these, they often have bright signal, will have very high ADC values. These lymph nodes are not going to be treated well with chemoradiotherapy. They're not going to reduce in size. If if your mind is wandering somewhere else, then this is what I want to really show you today. This is a screenshot from a different institute. Patient had this sort of bilobed cystic mass, and you can see the report clearly says that this is a branchial cleft cyst. As a trainee doctor, if this is something which you can carry home today, is that please think about P16 positivity, because a cystic nodal mass in a man is not always a branchial cleft cyst. And elderly, now what is elderly? Nobody wants to be called them as old. Even at age of 60 or 70, I would be hated if someone calls me I'm old. But the surgeons think that if you're above 35 or 40, and if you have a cystic mass in the neck, you don't have a branchial cleft cyst, you have a P16 positivity. So think about, 30 is old enough. We're all old, I guess, then. So it doesn't make me feel that bad. So this is another case where you can see a really large, bulky primary. Not going to spend too much time on it. This is the biggest problem we face in our institute, are young females. The youngest case of HPV positive patient I have seen is a 13-year-old female. So that's actually, you're in school. You should be studying, and you should not be doing something else. So, but that's the reason we see that. And this is a patient, and I will show you an example. This is a typical stock standard 30-year-old female, comes to the emergency department, thought that she had a neck abscess, gets treated with IV antibiotics, sent home with oral antibiotics. Here's your 6 weeks of course, and this thing never disappears. She comes back later at our other hospital. Look at the size of this monster. It is so big, and you can see the primary in the right tonsil, and she's 32 weeks pregnant. This is a very common scenario for us. These patients cannot undergo chemo-rads because they're pregnant. So then that means you have to deliver them early, the risk of all neonatal injury and all that, then only you can qualify for the treatment. This was our local publication, and we clearly found, which is same as what in the rest of the world, the primary is always tonsil. So you should always look at the tonsil followed by tongue base. Majority of them are in men. And then if you look at the Hounsfield unit value, the primary is very small, 2 to 3 centimeters. And if you look at the HU value, the lowest was 25. So they do look very cystic. So lymph nodes are not very solid looking. They don't look like typical necrotic nodes. The cystic lymph node is a very specific sign for this. And again, patient presenting with an infected P16 positive node is a very common thing. Here's a patient in June, had a cystic node, infected you give antibiotics, then you see the proper culprit of what it is. When we are doing a biopsy, as a interventional or head and neck radiologist, our reaction is to put a needle, stick into the middle of the lymph node and aspirate the stuff. If you aspirate that, you will get this yellowish material, which will be negative. That will be just debris. And that's why this is the reason why they have the highest yield of non-diagnostic FNA. And if it's a non-diagnostic FNA, no cell seen, that patient is reassured that they don't have a cancer. So if you're doing an FNA, the sample should be taken from the edge or capsule of the cystic lymph node. It's very, very important. This is an example. Again, this is a patient who presented with subacute combined degeneration of the cord and had a cervical spine MR. And you can see this was missed by one of our residents. You have a mass there and a lymph node. And look at that. The patient is from, this is 2019, and this is 4 years later. The neck is a complete mess now. Look at the extent of disease and how this lymph node has gone over 3-4 years. They're slowly progressive, but they will eventually get you. This is the point I want to make here. This is a pretty high quality MR, and most of us here would be very tempted to call irregularity. I'm not saying the capsule, I'm going to call external extension. No, not for P16. It doesn't matter. There's no point upstaging them because the E&E is not relevant in P16 positivity kind of tumor. You will also see the left tonsillar primary. Now, this is relevant that if you see bilateral nodal disease, then there are only two possibilities. One is the tongue-based lesion must have crossed the midline, simple as that. If it is tongue-based lesion crossed the midline, you're gonna see bilateral lymph nodes. But the commonest site is tonsil, then what's going on? So if there is a tonsillar primary and you're seeing a contralateral nodes, always look, the tumor must have gone, followed the palatoglossus arch and must have gone to the soft palate. We don't do a good job in assessing the soft palate, especially in the axial plane. So you look at it in the coronal plane, you will see the tumor must have crossed over onto the palatoglossus arch, onto the soft palate, crossed the midline. That will only give you the contralateral lymphadenopathy. So that's again very important. We did a similar study on a PET. We were too concerned or too excited at that time by the SUV value, but we found out that the SUV value of the primary is no different when it's P16 positive or negative. We're not concerned about the nodes, and doesn't really matter there because the nodes often are actually negative or don't actually have a very high SUV value because they are cystic. So the nodes are not that relevant. What's important is because the way they are treated. If you're doing an FNA and if you're thinking of HPV positivity, it's really easy to add in P16 status. It costs $30 in our place, and I'm sure it's pretty cheap as well over here. So adding a P16 stain on a sample is really easy. These patients would not qualify for any surgery, and they will be treated with radiotherapy and cisplatin chemotherapy. And this is how usual workup is done. Here's an example on a PET and an MR. Left tongue bus primary has crossed the midline. So you can see this is where I spend most of my time. Usually I take a bribe of cup of coffee to go across to radiation oncology. And you can see that majority of the tumor on this side gets a proper dose, which is GTV, whereas the contralateral neck, you have mentioned it has crossed the midline. So the other side of the neck is also treated by your radiation oncologist. And I have a clinic, I see patients every Thursday, and you can see here, this is what happens. This is what radiation does to you. Most of these patients cannot even move their neck because 3-4 years down the track, they get this really woody, hard neck. And if you are actually putting a needle into it, it's like actually using a drill. That's how radiation does a massive fibrosis. Something needed to be changed in this area. And the change was, what are the head and neck surgeons going to do? They're going to twiddle their thumbs because they've got no work to do now because everything is treated with radiation oncology. So hopefully, and I'm pretty confident over 20, 30, 40 years in India, the HPV negative cancers are going to decline, and you will see more HPV positive tumors treated with robots. They don't look like this, but they look like this rather. So this is the Da Vinci system, which I'm sure there are a few in here as well. So, and can be operated remotely as well. I showed a case yesterday. So we play again a big role in that area. So if it's a T1, T2 primary where it is tonsil, you don't want patient to go through the chemo rads, well, your surgeon might be interested in this sort of small kind of case. And again, if you can show that on dual energy CT, you don't have to rely on MR or PET to show what the primary looks like. And why is it important? The reason for that is this is what happens. If they're going to have robotic surgery, the incision usually involves deep to the pharyngeal constrictor muscle all the way down like that. That's how the incision, of course, is done. So if the tumor is if it's going to retromolar trigone, buccal space, glossotonsillar sulcus, well, the robotic surgery is not going to work. And this is where we make the difference. Here's an example of how a robotic surgery is done. You can see there are 3 arms installed through your mouth. Most of the tonsil has been dissected. You can see the bit of burning, barbecuing there because of, and then you can see the tonsil is now resected and is pulled out of your mouth. This is how a robotic surgery for tonsil is done. And then the patient doesn't have to have chemo rods after that. And that's the relevance of it. We do make a huge difference if the patient has got an infiltrative primary. I'm going to finish in a couple of minutes. If the tumor has gone beyond into the masticated space, if there is retrofacial carotid, or if the neurovascular bundle is involved, patient cannot have robotic surgery. And we would mention this. If there are young families out there, please get your kids the HPV vaccine. It's offered free in Australia for every child who is in grade 8 or grade 9, if for it, and protect your next generation. In summary, I've gone through what an HPV positive tumor looks like. It is very different. It's a new type of disease, and it is definitely changing the landscape of how we're going to see oropharyngeal cancers in the future. So this is a new type of disease, been around for the last 5, 8, or 10 years, and be careful how you report them. Look at the Huntsville unit. If you see cystic node, don't dismiss it as branchial cleft cyst. If you're doing an FNA, make sure you take a sample from the edge of it and be aware that this is going to go from a different AJCC classification. And we make a huge difference in the patient's management. Thank you.
Hello. Thank you very much, Dr. Sandeep Bhutta. It was a fantastic lecture, and your stress on HPV for us in India came at the right time. I think it's important that we all have to look after our children, especially before the teenage, need to ensure that they are all vaccinated. Because of lack of time, we are going to go ahead with the next one. But thank you very much for your presence here. On behalf of organizing committee, I take the liberty of thanking you for your presence all the way from Australia, and we will keep in touch, of course.
Thank you so much.
Thanks very much.
I really appreciate it. Thank you.
Thank you.
Thank you so much, Dr. Sandeep. For the next session, we'd like to call upon Dr. Matthew Cherin, Chief of Radiology and Intensive Services, KMCH, Organizing Chairman, SOIICON 2025, for his talk on can subspecialization protect us in the era of AI.
So Anbroso knows this talk because it was originally made for him. And sorry, this was actually a filler. Somebody else was supposed to be speaking and he's not there. Having looked at it, maybe this talk would have fit more on the other hall. But nevertheless, more than anything, I will show you a style of presentation. So today I'm going to talk on can subspecialization and interventional radiology protecting us from getting redundant, So imagine the sun is shining really hot on top of you. You need to have the beach umbrella. You're going to get skin cancer. You're going to actually die because of that. And the whole talk today is what is that umbrella that's going to protect you in the field of AI. Nothing in the world teaches you better than history. So we need to know our history to know what happens. It was 1895, Röntgen discovers X-rays. Then for 55 years, nothing happens. Just imagine that half a century, there is nothing happening at all. We are still stuck with X-rays. 50 years later, Donald makes ultrasounds, Now this could happen because it is at this point of time that computers come into medicine. Then from 15 years later, we have got CT scan and Hounsfield is so well known to it. Then a drop, 10 years later, we got the MR. Now imagine 55, 15, 10, and now computers are coming in a big way. But the only problem, these computers are bulky, they're huge, they occupy space, they're slow, but they're getting smart and we are going somewhere. Now what happens in the next 2 decades? From 77 to 2000, things start really moving fast. And why do they move fast? Because our computers are getting better and better, they're getting smarter and smarter. So we got CT and MRs doing better job, faster, better imaging. Now we fuse PET and MRI, DSA and CT, 3D and PACS. There is no end to this combination we do. And from 2000 to 2020, radiology becomes the most lucrative thing ever in the world. Now, everybody is gunning for radiology because we can do so much work so fast. But the big headache now is I don't have manpower. We are never prepared that we'd be doing these millions of investigations. And that point of time, somebody comes up with the idea, why don't I give you a tool that can actually help you report? And AI sounds like the perfect gift. And every field of medicine was growing exponentially. Name it, whether it was renal disease, whether the genetic understanding, or whether it was neuroradiology or understanding of infectious diseases, robotic surgery, laparoscopic surgery, critical care, they were growing exponentially, and they were looking for rapid, fast answers, and we read it in the next hour, not after 3 days, not after 4 hours. And AI seemed to meet every single need. It's instantaneous, 20 seconds you got a report. And therefore, we thought that we had to change in our department. So what did we do? We decided to grow beyond so that we were ready for AI. So in 2014, we were one department, happy together, everybody sat together, one boss, good or bad, I do not know, but that's it. My word was the law, and that's how everything worked. It was pretty peaceful, actually. But then, this was not the way to grow. So we decided that we had to change. We sat together, talked together, discussed this across systems. People were posted from ultrasound to CT in different days. But the fact is, we had plateaued. We were not growing anywhere. And nothing real is happening. We are not even publishing much. We people started finding this a job. So we decided to break things up a bit. So how did we break this up? One morning, we decided to call everybody up and said, look, we are splitting you guys up. You're going to become divisions. You're going to have subspecialties, and you're going to become a lead by yourself. What are the response? That's actually Rupa, by the way. She's here. She was the one who was so excited about this. But not everybody is excited. Somebody said, this is crazy. What if I lose my job? What if I leave KMCH? Where do I go? But the truth was, what happened in the next 5 years was phenomenal. The pawns, the unknown people in the group were suddenly promoted all the way to the top. They became key leaders. They started getting recognition at the national level, and they become experts in their specialty. And then everyone in the group was now a winner. That's no doubt about it. In the next 10 years, they were known across the country because they were so good in so less. So what are the lessons we learned? To grow, we have to give up something. From a general radiologist who reported many symptoms, we gave up many to become absolutely phenomenally good in one area. And that, honestly, is the key. It is the perfect key to our growth. And we grew. We grew rapidly. We published. We were recognized at the national level, even at the international level. At the same time, what was the impact we had on subspecialties? Now, these people also found it a much better relationship because we understood them much better and we could talk to them. But the problem there is still what happens if the quality of AI keeps on giving better and better reports? Do we become redundant? And that was a challenge that always there in our mind. But the truth, what was happening was that we realized that we had to keep on evolving in a direction that would keep us protected. So we decided we should transform the very attitude that we have. What's a transformer? Low voltage current to high or high to low. So we decided the low voltage radiologists who just sat with their monitors, did not talk to the patients, had to change their attitude, and we had to now become clinical radiologists. So what being a clinical radiologist? Basically, it meant that we had to create an environment for the radiologist, the clinicians to come and spend time with us, talk to us, and maybe in a way, make them feel we are indispensable for their treatment and planning. So the first step, therefore, was we gave separate areas and separate rooms and enough space for a clinician to come and sit and have a talk. He didn't have to stand or be a disturbance, The second step, what we did was actually created that's what I said, created an environment for people to talk. And step 3, we started talking their language. We understood their surgeries, knew exactly what was the way they would need planning. It was just not a random report which made no sense at all. We could actually work into their system. So in the end, what did we achieve? Now they found it easier to reach their goals. We could now solve their problems and puzzles for them. Many, many times they realized we were almost like a life-saving device for them. And therefore, what we created was we became a system that closely engaged with one another and we could talk well. So what did we achieve so far in these couple of years? We had a great relationship of trust, mutual respect and dependency between the clinicians. They respected us, we worked closely with us, but still behind our back we knew if AI could solve and talk like us, they would just throw us like dust in a dustbin or scrap and walk off. So this also we felt was not good enough. We knew it was fine for the time being, but AI was just a kid in the block. In the next 10 years, it would go to something phenomenal. And then it could be terrifying. And the more I look into it, the more we say AI can't solve it, the more I'm surprised with the quality of reporting is getting better and better. And therefore, there is a very significant chance I can be redundant and get solved. So we decided we had to do something even better. We had to have a system in place that was so strong a defense that it could not be penetrated. So we thought, what if we give image-guided intervention to every subspecialty and not just keep it just to AR and IR? So angioplasty and embolization procedures were anyway done by IR. So we decided what happens if we give drainage procedure abdominal group, or for example to the subspecialty. What happens if we give ablative therapy to the groups that we're working? And do you think this could be better? Because AI finally cannot put a needle. We had to plan it, we had to execute it, and we finally thought this truly could be the answer to this problem, right? And so we went ahead. So why don't we create clinics for one another? Now the fact of the clinic was not something new. Here we could see patients, talk to them about procedures, talk to the clinicians too about it, but at the end of the day, we actually were going to do minimally invasive surgeries. And it's important we realize we discuss everything to a clinical specialties, you do even process of fee sharing to make sure that they don't feel threatened and they didn't feel that we were pushing them out. And that basically was the aim. And we anyway had this model actually working for us. In 1991, when I joined, we started an IR clinic back in 1991. And it was working out well actually. What we did basically was we would actually see patients, we would examine them just like how a clinician would do. We would do the appropriate imaging for them. We would do the right procedures. We admitted the patients, did the follow-up for patients, kept in touch with the referring physician, and that worked perfectly fine. We also did a lot of education, both to the patient and the clinicians, trying to make them understand what exactly are we doing. And the physician education was important because they had to understand that we could deliver things that they were not aware of. But at the end of the day, 10 years later, we were treated like fellow clinicians. They completely forgot we were diagnostic people. And what started as a vague dream would finally turn totally mature into almost a technicolor painting. It was complete, it was mature, it was fabulous. So what we needed was to try to see, can we replicate this model? And honestly, it took 20 years for us to replicate because somehow even I did not have this vision that this is how to go. Like I said, we were one head and just taking care of everybody. Now we are getting multiple heads to take care of many people, each having their own subspecialties, and each one of them had to become clinicians. So therefore, we had to start clinics. So the first clinic we started out after that was the breast center. Basically, it was Rupa who wanted this done, and then we had women's imaging. They did exactly the same thing. They examined every patient. The hospital was willing to do that. They discussed with the surgeons about appropriate imaging and appropriate surgical planning. Imaging, they decided. Surgical planning, they performed biopsies, placed wireless, put localizers, treated papillomas and fibroadenomas with WAB, and they were a specialty by themselves. And they became like multiple cogs in a wheel that worked absolutely and phenomenally. For example, they could make a proper diagnosis. They would plan the appropriate treatment. And then once that was done, they would counsel them for appropriate therapy. and interventions whenever necessary. So they were actually a boon for the surgeons. They found it really good. And now we felt that we had something in place that honestly was AI proof. So once we had this in place, we divided the whole department and encouraged everybody to start their clinics. So we had the abdominal group and ablative therapy. This is actually done by Venkateshan's group, and they started looking at the abdominal procedures, ablation of abdominal tumors, even helping surgeons enormously with treatment planning and surgical planning, especially in transplants. And sooner than we imagined, we realized we could bring other specialties inside. Another area which works extremely well is MSK. There's a whole lot of minimally invasive procedures that can be done, just not biopsy, but there is RF, there is pain relief management, and therefore, working in this way would make us minimally invasive clinicians rather than just diagnostic people. What about people who worked on the, for example, pulmonology or any of these groups? We found we could engage with all of them. But there were some specialties that was not possible. One of them was cardiac imaging. Another one was advanced neuroimaging. What we found, the big problem we find today is we get a lot of people interested in neuro intervention, nobody for diagnostic neuro work. And therefore we realized if we had to preserve them, we had to start doing extremely complex imaging. Imaging that the clinician truly cannot understand and needs tremendous engagement from the radiologist. So we started doing work on epilepsy, functional MRI, tract sparing surgeries, where again they were necessary to work with the surgeon. We created the same thing for cardiac work, for ablation. They need to actually know whether there's a scar or not. They want to know what's a myocardium. And so we realized that these were areas where we focus much more than the standard things to ensure that these people too were protected. So what exactly are the challenges in implementing what I spoke so far? And the challenges are the HODs. Many of them refuse to change. They do not think of what will happen ahead. The first fear is of losing my identity. What happens if I make so many leads? Will people stop calling me? Will my importance be lost? Will I be nobody at all? In reality, that never happened. Let me assure you, I became bigger when I broke the department up. The second thing many people have is, anyway, I'm going to get retired. Why should I even bother? By the time AI comes up, I won't be there. And that again is a very, very, very fatalist attitude. Because it doesn't affect me, I don't care. But the truth is, we have to remember this. History teaches us lessons that we should not forget. For example, in India, for many of us in school, HMT watches ruled the watch industry. Today, they don't exist. Why? Because when quartz watches came, HMT felt it was not necessary. Indians won't take quartz watches. Titan rules and HMT disappears. We use films from a company called Hindustan Photo Film. The factory is in doldrum. They don't exist. When digital imaging came, they thought India will not go for digital imaging. Alpha, Kodak, and Konica rules today. They don't exist anymore. And the same thing will happen with general radiologists. You sit back and say, no, India may not happen. It doesn't happen. Whatever happens across the globe, if you don't keep your ears open and listen, AI will knock you off. If you need radiologists, but not the type of radiologists you think of being simple work which anybody and everybody can report. So the bottom line is, when you see dark clouds, you take your umbrella. You know it's going to rain. Only a fool will not go to the umbrella. And the truth is your umbrella ready? Because sooner than you realize, AI is going to take away a lot of your work. And India is a country with a severe shortage of radiologists. And it's better to think about it now rather than late. So this is our department today. We got every division working together, and we call ourselves as one team with a dream. And that is to excel and be ready for AI. Thank you. So interestingly, this is using a tool called whiteboard.
Thank you, Matthew. Remember that, for the AOCR, I want you to give the keynote speech. Yeah. And the exact topic which was given to you was that, people are afraid of AI because we had so much sessions on AI during AOCR. And we want you, as the senior intervention radiologist of the country, to guide the young generation. You've been a great mentor, you got mentorship award and things like that. And the way you did in your department, it actually helped all our, these guys are one of the top radiologists in every subspecialty association in India. It has helped tremendously. I have given them, each one of them, workshops and halls to handle completely during the AOCR, and they did it at the international level. So the change you did in your department is reflected in every association and also in every conference. The small changes has actually reflected. This is one of the greatest guidance which we could ever get, and timely as well. And again, on behalf of all of us, should we say thank you again and happy birthday again?
So, by the way, I told you this is a different set of presentation called whiteboard. So why did I use whiteboard? I have a challenge in my department, I'm very finicky about presentation. So I tell every presentation that goes to my department, I want to see it. Many of them bring it to me. But then I had to also keep ahead of the loop by showing I can do something better than the rest of you all. So this is a very interesting platform, just very intense engagement. People tend to focus on it. So
yeah, I still remember your, I think it's Rupa's talk on pelvic imaging, which you edited and several times edited and created.
It was
That's for ICRA teaching. That was a simple ICRA teaching for about 40 minutes. And he was working on her, and they were, it was amazing result which has come out. One of the finest talk Rupa has given for just for anatomical. That was be in charge of ICRA anatomy. Just weekly once we had this Monday talk on anatomy, and that's where she gave that fantastic. I still remember that 5 years ago you were actually trying to edit that talk. And
no, I'll tell you why I do this, because I don't think the quality of a talk should depend on the quality of your audience. The quality of your talk depends on your character, And I don't think your character should change. So I tell you, even if it's for classroom teaching or it's for a big audience, let your quality flow. So I think our department makes the best PowerPoints in the country. We are very finicky on how it should be done, and we are bothered about these small details. But I think in the long run, even our PGs, just last Monday, Tuesday, Wednesday, we have the very interesting exercise where all the postgraduates from the logbook present best case. And Sanjeeva from Harvard was there. And he was amazed. He said, I can't believe this is your standard PGs, because the quality of the presentation is way up. So we sort of encourage them. I think in the long run, I always feel just because you're Indian, don't think you're inferior to anybody. Show them you're better than the rest. So wherever you are, I feel, show your quality. That's all.
And also all these softwares which has been created all around the world, although it is branded as American companies, it was all created by many Indians behind it.
Unfortunately, that's one problem.
We are using our stuff.
I don't know if I have time, but I was actually talking to Chandrasekhar, CEO of Tata, and he was in a hospital, the Ganga Hospital. It's a question answer session. And I asked him this question. Just tell me one thing. You make billions on software, yet why don't you have one product? One Microsoft Office from Tata called the Tata Office. And seriously get no answers. And that's the interesting thing about China. China called these guys from G, from Philips, from Siemens, and told them, we'll give you the same environment, the same salary, the same place, build us United Imaging. And they did it, So why doesn't India do that? I don't know. All our guys are so excited. CEO of Google, Indian. CEO of Microsoft, Indian. CEO of everything, Indian. Tell them, we'll pay you the same salary, build the state of in India. 40% or 50% of your work power is Indians. What he said is right. It's just like what the British did. They made us make indigo here. They used to export it and linen to England, and then make us 10 times more and buy it. Now they have their factories actually sitting in Bangalore for Siemens, for Philips, for G. We make the same softwares, export it to US. They make us buy 100 times the cost. Nowhere different from the British era,
Hopefully we'll see the change as well for that particular. Meaning we have been knowledge user, knowledge teacher, but we never been a knowledge or a product creator. That is where we are have to change.
That's where the made in India thing is really going to change. So I can go on talking, so I better run off before it does, because I love talking. That's my biggest problem. So thank you.
Thank you, Matthew. I think we will close the session and head for lunch.